have every.
Now you start. Palani, you started before time.
Good afternoon, all of you have gathered here. I welcome you all to the ICOG Masterclass 12th May, which happens every Friday. And we take a themed topic, either obstetrics, gynae, or infertility, and we go on under the stewardship of Dr. Lakshmi Shrikande, chair of the ICOG. And today we've gathered up topics called AUB, Always Uterus Blamed. So the theme of the topic is, in AUB, should always the uterus be the blame, or should somebody else take the blame, whether it's the ovary, whether it is the adenomyosis or something else, or can we do something else and not remove the uterus is probably the theme of the whole masterclass today. And with that small introduction to the topic, I'm sure the speakers, would be introduced later, and they're all absolutely brilliant speakers today. And with that short note, let me ask Dr. Alka to take over, who's the master of ceremonies today. Over to you, Alka, to conduct the proceedings with Dr.
Sir, I'm audible?
Yes, you are audible.
So good evening, everyone. I welcome everyone for yet another ICOG masterclass today on abnormal uterine bleeding, always uterus blamed. So I'm Dr. Alka. I'm the assistant professor in OBGYN department in Sri Ramchandra Medical College and Research Institute, and I'll be doing the master of ceremony today. So I'm very proud to welcome Dr. Lakshmi Shrikande ma'am to our ICOG masterclass. She's our chairperson of ICOG Indian College of OBGYN, our national corresponding editor journal of OBGYN India Jogi, national corresponding secretary association of Medical Women India, founder, patron and president of ISOPAB Vidarbha chapter, chairperson of IMS Education Committee 2021-23, president Association of Medical Women Nagpur, Nagpur Ratan Award at hands of Union Minister Shri Nitinjit Gadkari, received a Bharat Excellence Award for Women's Health, received a Mehru Dhara Hansoshya Best Committee Award for her work as chairperson in HIV or AIDS Committee, FOGSI 2007-2009. She also received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child, senior vice president of FOGSI 2012, president Menopause Society Nagpur 2016-2018, President Nagpur OBGYN Society of 2005-2006. She has delivered 11 orations and 450 guest lectures, and she has 30 national and 11 international publications to her name. She has sensitized 2 lakh boys and girls on adolescent health issues. I welcome Dr. Lakshmi Shrikande ma'am for our today's ICOG masterclass.
Thank you. Thank you so much, Alka, for your kind introduction. Palani, should I say here or later? What is your sequence? I don't know. Palani, unmute yourself.
I don't know. I'm sure the inmates will know. Please go ahead and start. I'm not the first speaker. You can introduce the symposium, and you can hand over back to Alka so that she will introduce Bas.
Yeah. So thank you, Alka, for your kind introduction. You can please stop the screen sharing. Hi.
Okay. Shall I introduce the first speaker?
No. Alka, just let me give welcome address as ICOG.
Sure. Okay, ma'am. I'll stop the shares.
Yeah. So hi, everyone. Very good afternoon to one and all. As ICOG chair, I am happy to be back with you all once again with our ICOG masterclass. And as our convener, Dr. Palaniappan has already told you, the theme of today's masterclass is whether apart from uterus, can fibroid, adenomyosis or other pathologies can also take the blame for abnormal uterine bleeding. And the topics and speakers are very well chosen. As you all can see that Basam will be speaking on palm point, which we all should follow in our day-to-day OPD practice. Then none other than Dr. Suresh will be talking on ultrasound. Dr. Sujata is facing some network issues, but I am sure she will log in soon. And she is also speaking on a very, very important topic, that is endometrial biopsy. Then I am speaking on the treatment of fibroids. Is the pen mightier than the sword? So this catchy title has been given to me by none other than our convener Palaniappan. So I will do my full justice to this topic, Palaniappan. And our Sunita Tandulwadkar will be giving a talk on lap myomectomy. Can it be done always? And Dr. N. Palaniappan himself will be giving a talk on adenomyosis, not an enigma. So friends, as you all can see, that we are trying to simplify and to update you all on fibroids and adenomyosis with galaxy of experts who will be sharing their wisdom and knowledge with you all. So without coming between you and your learning, I am handing over back to Dr. Alka for further proceedings and wish you all happy learning. Sujata, have you sorted out your audio problem? Great. Alka, yes, now you can introduce Dr. Palaniappan.
Okay, ma'am. So I'm very proud to introduce our beloved Professor Dr. N. Palaniappan sir. He's the head of our department of Sri Ramchandra Medical College.
Thank you. Enough, Alka. Dr.
Sir, I will reintroduce you when you come for the talk, sir.
Thank you. We'll introduce,
yes,
not waste time. Go on to Dr. Basar.
Yes, sir. So without wasting any more time, let's start with our first session. Our first session is going to be all about the management of abnormal uterine bleeding. And for that, I would welcome Dr. Basav Mukherjee, sir. He'll be talking on palm coin classification, its efficiency and deficiency. So sir has done his medical schooling from CMC Vellore. He is a FIGO coordinator for South Asia Safe Abortion Committee, clinical examiner for RCOG.
Yeah, yes, we'll go on to the talk. I think we'll just leave out the introduction.
Yes, sir. So over to you,
everybody knows everybody, actually. Everybody knows everybody. I think that's where we leave it. Thank you very much.
Yes, sir.
Yeah, I'll just take it from here. Thank you. Thank you. So it is a pleasure to be. Yeah. I'm good. Just yeah. It's a pleasure to be here on the invitation of Dr. Lakshmi and Dr. Palaniappan. A wonderful CME ahead. Hopefully, happy learning to everybody. And I start the ball rolling with palm coin classification, efficiency, and deficiency. So when we were in our, not in our postgraduate days, much later after post-graduation, we did come to know that FIGO has got this palm coin classification of abnormal uterine bleeding, and things have pretty much changed after that. And most of our attention has drawn on that direction. Just to give you some insight of abnormal uterine bleeding, like endometriosis, like polycystic ovary, it also has a negative impact on the quality of life of women. 5 out of 10 women report a large negative impact of their physical activities because of the bleeding. It also affects their relationship and their work environment and education. So I think it's a very important and pertinent subject that ICOG has taken up. We often do not look at the quality of life issues of heavy menstrual bleeding or abnormal uterine bleeding. We jump into treating them, we jump into giving them medical or surgical treatment. But I think we should just take a time off and also understand that this lady has the bleeding is affecting her, and she's having a lot of problem with that. Also, when we go out for our public awareness activities in schools, colleges, rotaries, and other corporates, we must understand that we have to discuss about HMB, because there's a large number of women who do not discuss about it, and they normalize their symptoms. They think that this is something normal, it just happens to everyone, so I'll be having it. They don't realize when their hemoglobin drops to 6, when they become anemic, and that's very important that we really bring it forward, that if you're showing signs of weakness and fatigue after your period, then there's a likelihood that it's heavy and you need to really show the doctor and get yourself checked. So the AUB impact on quality of life is something which is very important, and this is one of the main reasons why AUB needs to be diagnosed properly. And after 2011, thanks to palm coin, the diagnosis is more stratified and more simplified than it was before. So the spectrum of the problem, it's 18.2% in the reproductive age group in India, and we're mainly talking about non-pregnancy AUB, non-pregnant AUB, with a prevalence increase in age of 24% in the 36 to 40-year age group, and 15% of all gynae OPD visits and 25% of all gynae surgeries. So the FOGSI nomenclature, which came out in 2011, before that, the nomenclature we used to follow in our postgraduate days was different. It was inconsistent, defined, and I'll show you some of the terminology which was used at that time. Metropatica hemorrhagica, you used to pick our brains. You want to find out what Metropatica hemorrhagica is and how is it different from hypermenorrhea. And we just tried to figure it out in our brains, and it was quite difficult at one point of time. Just menorrhagia was simple, but the rest of it was quite complicated. And at different points of time, different people use different terminologies, and it was difficult exactly to gather when it's DUB, when it's Metropatica hemorrhagica, when it's polymenorrhea, and when it's hypermenorrhea. But now that thanks to the palm coin, we have crossed that phase in life. And as Dr. Lakshmi rightly put, that most of the clinical cases which we see in our clinical practice, we can very nicely classify them in the palm coin thing. For palm coin, people who still need to be sensitized, well, there are two categories of this: so polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. That's the palm part of it, which is something which you can structurally see and manage. And then the ones which you cannot see: coagulopathy, ovulation dysfunction, endometrial issues, iatrogenic, especially usually related to drugs, which is either a drug which you've given, a hormonal or a non-hormonal, and the not otherwise classified, on which a large part will be the AV malformations. So the first part in the palm is the structural causes of heavy menstrual bleeding or abnormal uterine bleeding, what you like to say. So these components are discrete, measurable visually, and a large proportion of today's discussion is on this part of AUB, quite rightly so, because this is what you usually see in your day-to-day practice. But also you can see ovulation dysfunction. We always see in the coin part of it that, like in the polycystic ovary patients, you have a lot of ovarian dysfunction, and whenever there's an abnormal irregular bleeding, there's often a tendency to be heavy bleeding for reasons which we already know. So that's so this is the palm coin, and I think all of us are reasonably conversant with this. So when you have a patient with abnormal uterine bleeding, you write it as AUBP, AUBL, AUBE, AUBO before you actually, when you're in the final diagnosis. So people generally are understanding what it's all about. And the reason why it helps is that once your prescription is seen by a peer gynecologist or by a peer person, he or she will be able to appreciate and understand what exactly you're meaning by that. And then, of course, the leiomyoma subclassification came into later. And then so one of the biggest things of palm coin is, oops. I'm sure it's back here. So biggest thing of palm coin is that you are able to relate to what exactly the problem is. So once you say it's AUBL, everybody will understand it's a leiomyoma causing heavy bleeding and a leiomyoma somewhere lurking out there. So the FIGO recommendations of terminologies and definitions for normal and abnormal bleeding came along with the palm coin, and there we had come with these suggested normal limits of menstrual parameters in the mid-reproductive years. This also is something which you can understand and say that when is a menstruation called to be frequent, when it's less than 24 days intervals, a normal range of 24 to 38 and more than 38 days would be less termed as infrequent. Similarly, in the same way, like regularity of menstrual cycle to cycle, there is variation, duration of days of flow. If it's less than 4.5, it's shortened. A lot of people come with that, and more than 8, it is prolonged. So the two FIGO systems for normal and abnormal uterine bleeding symptoms and classification of the causes of abnormal uterine bleeding in the reproductive years came with 2018. There were revisions, and the normal variation shortest to longest was 8, 7 to 9. So the definition of regularity has been changed, where the shortest to longest variation is up to 20 days and variation of 7 to 9 days, depending on what age you're looking at, because at different age groups, there are different bleeding terminologies. And also there's one more change, that the category N had undergone a change from not yet classified to not otherwise classified, which cannot be certain because it may still go into one of those classifications. And that is the other changes which happened in the 2018 modification. This is the myoma classification, which often we see, and a lot of people do use it when they have discussions on lap myoma or even on open myomectomy. I'm sure Dr. Sunita in her talk later today will be putting up this picture, which I think most of us are more or less familiar with, and we have the issues of what 3 and 4 does to subfertility, 5 does too. And the 2, 1 and 0, 1 and 2 is more or less things which need to be dealt from by a hysteroscope, and the ones externally by a laparoscope. And then, of course, the size multiple and a lot of other discussion regarding myoma. But it was important that the myoma also has a classification, because just saying AUBL is not enough. You really have to specify where it really stands to give a more correct picture to the person. And this myoma mapping, again, is a wonderful thing which you keep on hearing, a pre-myomectomy, where a 3D TVS or a MRI would sometimes score over a normal traditional TVS. So algorithms are very clear for the diagnosis of AUB, and that again has come up through this Palm-Cohen classification. So once you have the Palm-Cohen classification in front of you, you understand which way to go. So AUBC, AUBM, AUBE, AUBP, it comes up depending on the clinical history that you elicit and the examination findings much before you'd have your sonography done. So the clinical history, we know that is suspecting coagulopathies. There are issues where dental work, bleeding, or easy bruising in the adolescent period would give a suspicion of coagulopathy unless it has been checked. Usually later in life, you will usually may not get so many of that. Then you have the other issues, and then do the necessary investigations and take the discussion forward. So one of the things, advantages of Palm-Cohen is the streamlining of investigation and treatment, which is done so easily compared to things which happened before. So just the next couple of slides, we take you through that part of it. So the polyp, if it's a polyp there, you know what treatment to be done. You know it's AUBP, and that exactly warrants what kind of treatment is more or less certain. If it's AUBA, you know what exactly to do. AUBL, you know exactly, depending on the grading, where exactly you stand. So it's a very clear-cut management of AUB compared to what was before. And of course, there's one more point of advantage of all this is that you can, when you do a paper, when you do research work, it's easy to replicate, easy for people to make other people to understand what exactly it is. So easy for research, easy for education, easy for conveying information to patients or peers. So Palm-Cohen does have several advantages. So the takeaway home is that it standardizes the presentations of AUB, helping in education and research. You can create algorithms for each category for diagnosis and management in a clinical care setting. We didn't discuss about them in details because you will be hearing it from the other speakers, and also at the same time, it is just the classification that we wanted to deal with. Evidence-based medicine following Palm-Cohen can avoid unnecessary hysterectomy. A lot of things are streamlined, and we know that it's the Save the Uterus, the mission which FOGSI has taken a few years ago, has been doing wonders. First under Dr. Kalyan Barmade, he was the chairperson of the Public Awareness Committee, and then under Dr. Priyanku Roy, they have done a series of CMEs. I think they've crossed 50 all over the country, where saving the uterus has been the mantra, and the different ways in which you can intervene medically, also through the LNG IUS, where unnecessary hysterectomies can be avoided in many cases today. Reaching out to healthcare providers is always a challenge. So though you have this Palm-Cohen, there is a group of people who do not always attend conferences or who aren't updated, who will miss out on this. So this is something which you need to reach out to everybody. Also, making people adopt to change is a challenge. Whenever people they like to stick to what they already know, and that's the one challenge there. And histopathological changes may not always correspond with the system, and that is something which sometimes may happen, because though we know that there are HPE changes which may happen, it always doesn't go with what is there in the classification. Thank you very much. Look forward to hearing to the rest of the talks. Thank you.
Thank you so much, sir. That was a very, very short and very, what do you say, a packet-filled knowledge that you gave us regarding the Palm-Cohen classification, sir. Thank you so much, sir.
I'm sure you'll have questions, Basab, and happy to have you with us at the end of the 3 talks as well. And as usual, fantastic. And thank you. Yeah, Alka.
Thank you. Thank you.
We now move to our next speaker. I would like to welcome Dr. Suresh, sir. He is our Director Mediscan System in Chennai. He is also a Honorary Secretary, Voluntary Health Services, Chennai, Visiting Professor in Perinatology, SRMC, Chennai, and PhD Hospital, Coimbatore, Adjunct Faculty in IIT Madras. He started Mediscan in 1982, first ultrasound center in Chennai, conferred FRCOG by RCOG London in 2010, a past president of the Indian Federation of Ultrasound in Medicine and Biology, International Society of Ultrasound and OG nominated him as ambassador to India since 2017. Member of the Basic Training Task Force of ICOG, specialist in fetal medicine, performed over 25,000 diagnostic and therapeutic fetal procedures till date. He is well trained in fetoscopic surgery in Necker Hospital, Paris, trained over 5,000 doctors from India and other countries in ultrasound and fetal medicine. He has over 100 publications, including author of 2 books in fetal medicine, delivered over 800 lectures and 19 orations across the country and internationally, was awarded Champion of Chennai by KSA Trust in 2018, is presently transforming VHS Hospital as a destination of truly affordable healthcare with modern facilities. I welcome you, sir. Sir will be talking on USG reporting of fibroids and adenomyosis. Have we raised our standards? Over to you, sir.
Alka, you stop screen sharing so that he can share. Welcome, Dr. Suresh.
Lakshmi, can you hear me now?
Yes, Sujata.
Thank you.
Very clearly. Palaniappan is.
I'm just checking whether Dr. Suresh is there as well. Yeah.
Yeah. Because I really can't see him.
Yeah. I will just call. Meanwhile, Alka.
You introduce Sujata, and Sujata, if you are ready, we can go ahead with your talk. Sujata?
Not an issue. I mean, you tell me and I'm ready. No
Yeah.
problem.
No, I thought the next speaker is
Dr. Sujata.
Dr. Sujata.
Yeah.
I will call Dr. Suresh.
So since Dr. Suresh sir is not with us right now, we'll move over to our next session. I welcome Dr. Sujata ma'am. She is a professor and unit head of Department of OB/GYN, cum superintendent of PGIMR, Bhubaneswar, Odisha. She is a vice president of FOGSI 2015, secretary of Association of Obstetrician and Gynaecologists, Odisha, chairperson of Medical Disorders in Pregnancy Committee FOGSI, academic counselor, postgraduate diploma in MCH course, and special recognition as principal investigator, Cuttack site, WHO champion trial, also WHO Action Trial 1, Action Trial 2, and WHO Labor Care Guide Trial and Labor Study. She has been a co-investigator in Cuttack site for life trial as well as life trial extension. Radhanath Award for Humanitarian Services was also awarded to her, and as well Guru Gaurav Samman in 2021. She has plenty of publications to her name in various national and international journals. Madam will talk to us regarding endometrial sampling in asymptomatic women with thickened endometrial thickness. I welcome you.
Thank you, Dr. Alka, for those words. For the nice introduction. Thank you, Lakshmi. I'll just share my screen. Thank you. Continue. Yeah. Yeah. This is here, right? This one. See? 1 second. No?
Meantime, delegates, you can please post your questions in the chat box. If you are having any questions.
And there seems to be a problem today in every field. Huh? First it was the volume and now the sharing. But anyway, thank you, Dr. Lakshmi. Thank you, Dr. Palaniappan. The minute I get this done, I will.
Or you can email me. I will share for you.
I will do it right away. Yeah.
Yeah.
What's your problem? Huh? It was showing my screen when I tried, right? So let me just check on this. In this one, one second, I'll get it. Hmm? Hmm? Why the hell don't you do it?
I'll send folders.
We did share it right now, right? Lakshmi, I'm sending it to you right across.
Yeah, just email me and I will share.
Yeah.
Yeah, just wait. I think this question will be answered by Sujata in her talk. So just wait for her talk, and as soon as she shares, yeah. You have my email ID, na, Sujata?
Yeah, I'm sending it to you.
Yeah,
I'll right away.
Meantime, keep posting your questions in the chat box. If there are any questions for Dr. Basab on PAMCA in classification.
Yeah, I think we can go ahead with that tonight. And I'll WhatsApp.
Palani, what is the position of Dr. Suresh? Just unmute.
Yeah, just getting in touch. I'm just calling him.
Yeah, no
I've
problem.
called the secretary. He's going to call back.
Yeah.
Just see if you can get this done from here. I've given it. Lakshmi, I've sent it to you, and I'm just seeing if this comes through. Where is it?
Yeah. No. This is the.
It shows me only one participant can share at a time. What is the problem now? I don't know.
Mitali, तुम्हारा setting देखो.
Yes,
ma'am. Vignesh, setting देखो. Why she is not able to share?
Anyway, I've mailed it to you also, so that
हाँ, मैंने मेरा email ID किया है. मैं email ही check
No, I have mailed it to your email ID.
नहीं.
I
You have
WhatsApp it to you. I
send
WhatsApp
me.
it to you. You can send it to your mail.
Okay, I will do that.
And both of it. So, but why
Okay.
can't I share over here? Is my question.
Meantime, you can just answer one question posted.
Yeah. Basab, are you there, Basab? Basab? Dr. Basab, are you there? Okay,
No,
fine.
he has left. You will have to answer, Palani.
Yeah, I will answer. Can you please tell us the deficiency of PALM-Cohen's classification? Yes, it's been an absolute beautiful classification which we've got, but anything which is beautiful also has a discrepancy and a deficiency. If you look at the next talk, the endometrial thickness could be because of a polycystic ovarian disease. And where will you put the pathology now, whether it is on the ovary or whether it's on the endometrium, or you don't know. So it could be E and O. So your PALM-Cohen has a deficiency of classifying whether it is E and O. And when we used to write our diagnosis, we will say AUBL, AUBO. But here we'll have to write AUBE and AUBO. So that is about it. And next thing, what you have to do is when you have a thyroid dysfunction, TSH high, they will still have an abnormal uterine bleeding. Where will you put the diagnosis in the PALM-Cohen? Will you put it on others? Will you put it on O, or will you put it on the endocrine, or where will you put on is the question. So that is how it is going to be. And so these are the small deficiencies of the PALM-Cohen's classification. And when you have a polyp next is it's the endometrial polyp or a cervical polyp, then again, that is a deficiency of the PALM-Cohen's classification. It only says polyp, it doesn't say the area where the polyp arises from. That's one of the other deficiencies of the PALM-Cohen's classification. And the main difference is when you have endometrial pathology of malignancy, right? When you have a malignancy, would you put it, you will put it on PALM-Cohen M of a malignancy, or will you put it on the endometrium because it arises from the endometrium? So all these are the deficiencies of the PALM-Cohen's classification, and I'm sure I've answered the question. Happy to answer any more questions.
Yeah, no, let Sujata finish. I have shared her PPT. Sujata, can you see your PowerPoint? I'm sharing your screen. Yeah. Just unmute yourself. No, Sujata, unmute yourself. Palani, can you see her slides? I am sharing.
Yes, I'm seeing her screen as well, but there is
Okay.
today one, there is endometrial thickness, last one.
See, this is her CV slide. This is her first slide.
I'm not able to see your slides.
No, there is some.
Lakshmi,
Yeah.
just 1 second. Give me 1 minute and I'll get on with the slides and everything. Just 1 minute when you
Okay.
can. Yeah, I'll get on with the slides because I put it in another place. So, aa jayega fatafat. Just installing it. So, yeah, so if Dr. Suresh doesn't join in till then, I would like to make my presentation.
Palani, meantime, you can answer the second question which is there in the chat box.
What was the question? Let me see if I can also see.
Sujata, I think that was related to your age, more than 40 years, asymptomatic use finding.
Oh, yes. Oh,
18,
yes.
12 millimeter. Should we go ahead with endometrial sampling?
So age is more than 40 years and then?
She is asymptomatic. Age is more than 40. ET is 12.
Okay, 12. So I would like to ask further questions as to whether she is still menstrually active, she's having her cycles, and did you put Doppler in it and see it? And this is definitely going to be addressed in my talk as to whether you would do a sampling or not. Till date, there is no clear-cut guideline on what would be a cutoff wherein you would do and you would not do, and you can safely sit back and say that, look, this was this value and I did not do it and hence no malignancy. There's no guideline on this till date. In the postmenopausal patients, we still have some cutoff values, which was earlier 5. Yeah, now I've got, can you share my screen also? I'm leaving this, okay? I don't want two things, okay.
Sujata? No, you lost her. Sujata, are you with us? Palani, could you connect with Dr. Suresh?
Yeah, I connected with Suresh. He's just logging in. He just had an emergency and he said he thought it's only at 4:30, so he's just logging.
Okay, okay.
Dr. Sujata has left this and she's logging in another computer.
अच्छा, अरे मिताली इनको अनम्यूट करो, इन्होंने अभी डॉक्टर सुजाता मिश्रा के नाम से लॉगिन किया है. अनम्यूट करो. हाँ, मिताली, जिग्नेश.
यस मैम.
हाँ, इनको अनम्यूट करो, डॉक्टर सुजाता मिश्रा. किया?
यस मैम.
देखो सुजाता हुआ?
Yeah, hello, can you get me?
Yes, now we can hear you.
Perfect.
Yeah.
Please take that laptop out. So I will talk from here. So Dr. Planipan, can you see my screen also?
Yes, see in your screen, there is a PowerPoint saying endometrial thickness 12.5.
No, I have put it on full screen.
We can see
Yeah.
screen, but not the PPT. No, we will have to open it.
I have opened it. It's full screen. Let me close it and go again. Let me stop sharing and share again. Let me.
Yeah. That
Okay.
will be better. Yeah.
Thoughts?
That's
I will share this 80. Right.
there.
80.
Let me see if it's coming or not.
Yes. Sujata, we can see.
Finally, thank you.
Yes,
Okay, I'm so sorry for those little hitches. So
Yeah.
we'll go ahead to right away to the topic. Thank you so much, Professor Palaniappan. Thank you, Dr. Lakshmi, for having me here. When we're talking about endometrial biopsy in asymptomatic women with a thickened endometrium, how useful it is. So a thickened endometrium is always a clinical conundrum. The incidence of endometrial thickening in postmenopausal women ranges from 3 to 17%. Now, cancer and atypia can occur in asymptomatic women in a malignancy rate of 0 to 3% among asymptomatic postmenopausal women with a thickened endometrium. So, when we discuss this topic, what are our challenges? Number one, we need to remember the phase-related endometrial dynamics, more so in the premenopausal period if there's a thickening. Then the relation to age, meaning to say whether she is, as somebody asked me about 40, I would say perimenopausal or menopausal. How thick is another question, especially when she's asymptomatic. And again, I would go further on to just have a few slides on when to investigate, the modality of investigation. And I would still say that till date, no clear-cut guidelines exist. Now, just to recapitulate the menstrual cycle, we know that in the early phases, it's 1 to 4 millimeters in thickness. Then in the proliferative up to 12, 13, maybe 5 to 7 millimeters in the early proliferative phase, and in the late proliferative phase around 12 millimeters. In the secretory, it's around 16 to 18. We usually look at 16 as the cutoff. So when we talk about thickened endometrium, there's a fantastic publication by Professor Giri, Dr. Bhagya Lakshmi Nayak and Janmajay in 2021 February, which says there must still range as to the thickness of endometrium, which requires an intervention, mostly in symptomatic also perimenopausal women and in asymptomatic postmenopausal women. However, the dilemma also exists when you look at a cutoff with women on certain medications, on HRT, and on tamoxifen. A thickened endometrium alone does not always predict endometrial pathology. And to minimize the false positive results when you're following up on one, a routine ultrasound should be preferably done in the early proliferative phase, though the accepted threshold value is yet to be defined even in this phase. Various associated risk factors should be taken into consideration before you plan an endometrial biopsy, and the risk of pre-malignant endometrial pathology definitely increases in obese and diabetic women and with an endometrial thickness beyond 11. Now, 11 is not something which I want to be a take-home message. I am just quoting certain publications, certain observations, and we will come to a conclusion. Now, what happens is, if the endometrium is thickened and if she has no symptoms, then why in this whole wide world from endometrial cancer we graduated a little towards a more prophylactic side, and WHO brought in the EIN or endometrial intraepithelial neoplasia, right? Because we are right in a phase where we are doing prevention. So we don't want to really catch the cases of cancer who are already symptomatic. Hence, when the EIN classification came in 1994, and which was again modified, a new one came in 2014, I would just show you 2 slides on that to make you think as to whether or not we need to do a biopsy. So EIN is a complex atypical hyperplasia, wherein WHO 94 scheme said there is simple hyperplasia, there's complex hyperplasia, there is simple hyperplasia with atypia and that without atypia. Now, so what did the new one say? The new one which came in said just 2 categories. Either it is non-atypical endometrial hyperplasia, also known as benign hyperplasia, or it is atypical endometrial hyperplasia, right? And then when you have these EIN categories, they progress ultimately to a malignant stage. So the idea should be to catch them in this EIN stage, and not later. So for that, you need certain imaging modalities and you need certain interventions. So what imaging modality are we looking at? You can see a host of them written here, but obviously TVS is always a preferred modality of imaging. And if at all somebody would say, no ma'am, but a thickened endometrium, I did a SIS and I had a very positive result. Yes, if it's a polyp, a mucoid polyp, endometrial polyp, it will definitely show up much better in this. Now, let's look at the curve which came in, which talk value of endometrial thickness for detection of endometrial cancer and atypical hyperplasia in asymptomatic, which is what we are discussing, postmenopausal women. Now, look at 2,537 asymptomatic postmenopausal women who had a thickness more than 5. I would like to pause here and tell you, till now we were looking at a cutoff of 5 as the borderline for postmenopausal endometrial thickness, which rings a bell, but ACOG since long has brought it down to 4, and this is definitely a take-home message. So out of 2,537 patients, they picked up 968 patients. Of these, about 0.8% were diagnosed with endometrial cancer, while 0.5 had atypical hyperplasia. Now, even these 0.8 and 0.5%, which averages to about 8 and 5 number of cases, are important for us. Had we not done an investigation, how would we have come to this conclusion? Now, in this particular study, they decided, look, an ET cutoff of more than 8 millimeters is reasonable to perform. Otherwise, we need do an invasive procedure. So basically, when we talk of a basic procedure, what happens if we do pick up some positivities, but the prevalence rate is low, then they don't advocate that intervention. But does that really translate to practice is the question. In asymptomatic yet study, 266 asymptomatic postmenopausal women were studied, and they took the cutoff as 6. Well, these are individual studies, so they took a cutoff at 6. When they did the HP evaluation, there was no typical or atypical hyperplasia of thickness of the they pick up 0.1% of atypical endometrial hyperplasia, right? And beyond 20, it was about 12%. But on the same hand, they also did pick up some cases of endometrial carcinoma, even when the thickness was between 6 to 10, though it was just 2%. But and it was 9%, 20%. So what did these authors conclude? They suggested evaluation of the cases, even with a thickening in presence of risk factors. For instance, with increased vascularity, food addiction, endometrial thickening, sonography, or inhomogeneity. Yet in another paper, took up 72 asymptomatic postmenopausal women, and I would just read the last line. I don't want to go into details of all these studies. They said, look, the prevalence, we did pick up cases of malignancy, but the prevalence was low. So the effectiveness of TVS in the evaluation of asymptomatic population with a thick endometrium is a little limited compared to that of a symptomatic patient. Agreed. Where the risk of endometrial pre-malignant or malignant lesion would just be between 5 to 20%. So after a TV scan, would we like to do only a DNC, if at all we are doing, or would we do a hysteroscopic guided DNC? The favor is, the opinion is clearly in favor of hysteroscopy with a directed biopsy, which is more sensitive than a blind DNC done, which should not done anyways nowadays. Now, diagnosis of endometrial hyperplasia always requires histological examination. So we should do a diagnostic hysteroscopy. Then we've already done a TB scan, and you want to come to a better marker. To avoid overestimate of endometrial thickness, The measurement should always be made on the midline plane, not an oblique image. And to ascertain that the imaging plane is in the midline, the echo should be seen continuous with the endocervical canal. Typically, endometrial thickness is measured and reported as the sum of the two adjacent layers of the endometrium, which is the entire endometrial echo complex. Because once a report of thickened endometrium comes, it is then that everything else gets triggered off. It is also pertinent to know about the patient's age, day of menstrual cycle, any history of drug intake like HRT tamoxifen, in addition to clinical history and physical examination. Ideally, ultrasound scan can also be performed, which I said earlier, in the proliferative phase after the cessation of periods or around the ovulatory period for a focal endometrial pathology to be detected. Now, see, all these data which I'm showing you are basically as to whether or not we want to evaluate a thickened endometrium. So the incidence of endometrial thickening in postmenopausal women ranges, and amongst them, the malignancy rate could be 0 or could be, the consensus as of now is, though they don't have any cutoff value for a thickened endometrium, they definitely say that thickened endometrium, repeated again, along with the risk factors, definitely needs an evaluation. Now, this is a very good study with 3,600 women who underwent an office hysteroscopy. Okay, so of this 3,600 women, 154 post-menopausal women had a thickened endometrium, wherein they took it as more than 4, because ICOG says 4 nowadays. So on history, now those in whom they did the biopsies, so you can see that they're going very gradually, and they did not do a biopsy in all. Wherever there was a patient, the biopsies were done.
Sujata, we can't hear you. Hello.
Even if it is a thin endometrium, forget a thickened endometrium. Even if it's a thin endometrium, I'm supposed to talk only of asymptomatic. Just don't ignore it. Just don't say it's a thin endometrium and hysteroscopy did not give any tissue. An office hysteroscopy, guided diagnostic hysteroscopy, guided biopsy. Keep in mind that hypertension is in a high. If a lady, especially in the premenopausal age group, is on the proper group of antihypertensive, because of this, to change value, it would come. That's number 1. 2, AMI, that is obese patients, and diabetes can affect the endometrial thickness down by appetite. The insulin-like growth factor and its binding protein, which stimulate the endometrial cell growth. So, correct these, if there is no other risk factor, if the doctor is fine, assuring medical condition, and you may not want to do an intervention. Persistent exposure to unopposed estrogen is also a reason to have a thickened endometrium. Now, here I'll show you 3 trials again. The value of endometrial thickness for the detection of endometrial cancer study looked at endometrial carcinoma in postmenopausal women with just thickened endometrium. It was again cross-sectional. They said, "I've seen an increased frequency endometrial irrespective about the presence or absence of risk factors. The result of this study is justified enough for the need of further evaluation of a thickened endometrium in asymptomatic postmenopausal women. Yet another study all these are in PubMed. This said asymptomatic thickened endometrium in menopausal women. What did they say? They said cancer and atypia can occur in asymptomatic women. In this case, in 2 cases, this series, the endometrial thickness was more than 70 and formed. So having this except in the menopause with a thick endometrium. So SOGC says transvaginal ultrasound should not be screening for endometrial cancer. It is good for screening for a thickened endometrium, but not for cancer. But while SO says this, most other bodies say that for screening, the prevalence rate is very low. You can come to your own conclusions. Now, endometrial sampling in a postmenopausal woman, according to them, without bleeding, should not be routinely performed, but I'm sure we would like to do it. Indications for tissue sampling of the endometrium in bleeding women with a thickness of more than 4 to 5 should not be extrapolated to the asymptomatic women. And in this, we are talking only of asymptomatic. So they go on to say that do not do it in asymptomatic. They have said that thickening of more than 11 should be investigated further, and decisions about all other investigations should be on a case-to-case basis. In an asymptomatic woman on tamoxifen, don't even do a routine ultrasound for endometrial thickening is what they have said. And not all postmenopausal women who have asymptomatic endometrial polyps may require surgery because they are asymptomatic. Now, what does FOGSI say? We would always like to fall back on what FOGSI says. Well, I mean, there's nothing on a thickened endometrium in an asymptomatic woman, but I did take out a bit of a portion of the guidelines in management of normal uterine bleeding, wherein they have given certain recommendations for endometrial hypoplasia. So thereon they go on to say, we would not talk of what they say with atypia. Let me talk of what they say without atypia. FOGSI has gone on to say in AUBM, wherein they include endometrial hyperplasia without atypia, LNG-IUS can be considered as a first-line therapy. The gradation is A, level 1. Alternatively, oral progestins can be used. Preventive hysterectomy, of course, should never be done, so we won't talk about that. So if you look at the guideline which FOGSI says on AUB, I know I'm supposed to be talking on asymptomatic, but I just wanted to come here. Somebody had a question on this, Lakshmi, if you remember, whether or not you would do endometrial tissue sampling. If she is symptomatic, you would definitely do, as per FOGSI guidelines, a hysteroscopy plus biopsy in women more than 40 years, less than 40 years, or more than 40 years, and in women less than 40 years who have a high risk for carcinoma endometrium. For instance, irregular bleeding, obesity, hypertension, PCO, diabetes, endometrial thickness more than 12 is what FOGSI says, SOGC had said 11, and a family history of malignancy. So this should answer the question which was in the chat. Now, what has the British Gynaecological Cancer Society said? They are of the opinion that screening asymptomatic women even with a PV scan or sampling does not improve the outcomes from endometrial cancer. I don't understand this sentence because you definitely will pick up the cases of malignancy. So they've said routine evaluation, while not recommended, is a matter of concern for a clinician and should be a high risk factor based. The last one would be the ACOG guidelines, wherein they have said transvaginal ultrasonography is appropriate for an initial evaluation of postmenopausal bleeding, and it is symptomatic, and it is a reasonable alternative to endometrial sampling as a first approach. It's useful in the triage of women in whom office endometrial sampling is performed, but tissue may be insufficient for diagnosis. Failure to adequately identify a thin, distinct endometrial echo in a postmenopausal woman who is symptomatic should trigger further examination. We will not do blind sampling. So friends, to conclude, a histopathological evaluation definitely has a diagnostic role in evaluating cases with a thickened endometrium which are persistent, not too many, there are certain maybe risk factors, it continues, you would like to keep a record as a baseline. At this juncture, nor you nor me can declare it as a symptom, but if it exists the history or risk factor, we need to do it. The studies have definitely shown a positive correlation between atypical hypoplasia and malignancy, though the prevalence rates are low. Analysis of risk factors, follow-up, and patient customization is essential. Thank you very much for the patient listening. I have stopped sharing.
Yeah. I hope you have already answered all the queries. If there are any questions in the chat box, we can't see.
We have Dr. Suresh on the line, so I thought let him also finish off the talk and we can go for questions.
Sure.
Yeah, Alka, over to you, Alka.
Yes, sir.
Sujata, meantime, you just go through the questions posted in the chat box and you can answer there also.
Yeah, I'll see them.
Yeah.
Yeah, I'll see that.
We will take Sujata ma'am's all questions in the later on after Suresh sir's session. So I welcome Dr. Suresh sir. He is a director of Mediscan Systems, Chennai, India. He is a honorary secretary of Voluntary Health Services, Chennai, visiting professor in perinatology, SRMC, Chennai.
You already introduced him to the audience. Alka.
Yes, ma'am. Yes, ma'am. So I'll.
Everyone knows him.
Yes, ma'am, that's very true. So I welcome you, sir, and sir will be talking on USG reporting of fibroids and adenomyosis. Have we raised our standards?
Yes.
Over to you, sir.
We are eagerly waiting to hear from him. Yes, Dr. Suresh, please.
Yes. Good evening. Are you able to hear me?
Yes.
Okay. Let me share my screen.
Yes, please.
Okay, my screen is seen as post.
Yes, sir.
Okay, good evening, and thank you very much for inviting me for this talk. I'm going to make it very brief and very quick because we are considering two situations. One is fibroids versus adenomyosis and how good ultrasound is and what are the specific features for fibroids and adenomyosis. So before we move further, let us look at the normal myometrium in a person before menopause. Here is the transvaginal scan of a myometrium, which you know the transvaginal scan is the gold standard. You have an endometrium which is in the middle, depending on the phase of the cycle. We all know that the endometrial finding is going to change. The myometrium is uniform and homogeneous. We will find certain hypoechoic areas here at the periphery, which represents some vessels in the myometrium. But otherwise, the myometrium is uniform and supposed to be what we call as uniformly echogenic. The word echogenic in ultrasound actually means some degree of reflectivity it's sort of subjective, but you can compare the myometrial echogenicity with the echogenicity of a normal liver in a patient in the abdomen. And we have to ensure that we see the fundus, the body, and the cervix, and we follow the uterine cavity. The shape of the uterine cavity is also important because if there are fibroids, we are going to look for distortion of the cavity. Right. So the morphological uterus sonographic assessment group has given some sonographic features for myometrium and uterine masses, and there's a consensus opinion. And that's what we are going to see about how to describe these uterine masses and have some specific diagnostic features. So the common myometrial pathology is going to be leiomyoma and adenomyosis. And rare, of course, is calcifications and enhanced myometrial vascularity, which is what we are not going to touch upon today. Now, the most common benign pathology is going to be leiomyoma, which is a benign smooth muscle tumor of the smooth muscle. As you can see, we can classify the location of the myomas as one as submucosal. The ones in pink are called submucosal. And in the submucosal type, we can have pedunculated intracavitary myomas, as you can see here, or less than 50% intramural and greater than 50% intramural is what you can see here. So the moment you see a submucous myoma, we classify them as where they are located, either intramural or more projecting into the cavity. Now, this assessment is going to help us to actually identify the fibroids, which can be probably removed hysteroscopically. Now, the other ones are, number 3 is contact endometrium, 100% intramural. So you have a lesion here. Let's say, for example, lesion number 3. It's entirely in the myometrium, but there is a portion of the fibroid is actually touching the endometrium. So there's a contact with the endometrium. The lesion number 4 is completely intramural, where you will find no distortion of the uterine cavity. And lesion 5 will be subserosal. So here you can see a subserosal fibroid. It can keep growing out of the serosa. And more than 50% will be intramural. Or you can have a subserosal, where less than 50% is intramural. Majority of it is extramural or outside the serosal cavity, and beyond the serosa. Then the 7th one is a pedunculated fibroid, which is completely outside of the uterus. And this is sometimes can be seen in the adnexa, can be mistaken for a broad ligament fibroid, or could also be cervical, sometimes called as parasitic fibroid, where it's completely outside the uterus. Now, there are what are called as hybrid leiomyomas, which impact both the endometrium and the serosa. And that's what you see lesions between 2 and 5. You can see them distorting the uterine cavity, but they are also projecting outside the serosa. So the once we identify a fibroid, we are going to find the location and precisely report on the location about where they are. Right. Now, when we look at a myoma, we are looking at 3 things. One is echogenicity, the second is shadowing, and the third is vascularity. So let's look at the echogenicity. Fibroids can be uniformly hypoechogenic or can be uniformly isoechogenic. And this is the fibroid where we have a huge amount of difficulty in differentiating between this and a focal adenomyosis. And then you have uniform hyperechogenic, which is there where obviously the fibroid is brighter than the surrounding myometrium. And you also have non-uniform mixed echogenicity, which is often seen, especially with larger fibroids. And you have non-uniform with echogenic areas, where you can have calcifications of fibroids, or non-uniform with cystic areas, which actually represents the cystic degeneration in the myoma. So, so one is echogenesis. So here you can see a uniform hypoechogenic myoma, and then you can see a uniform isoechogenic myoma, almost equivalent to the cavity. And the one feature which is going to help us to differentiate between this and adenomyosis is the presence of a distinct capsule. You can see a very distinct capsule surrounding the myoma. And third is a uniform hyperechogenic myoma. It is a little less common if you come across. But if you see something like this with a very well-defined border, then we still call it as a myoma. Then we have a non-uniform mixed echogenicity, where you can see a heterogeneous pattern, or you can have non-uniform with sharp echogenic areas, which could represent calcifications. Calcification can come in the periphery or sometimes even in the middle of the myoma. And then you have a very different kind of a picture where you have a non-uniform myoma with multiple cystic areas, possibly representing cystic generation. So when there are atypical features, it's quite important that it is referred to a specialist who's doing more work in this area rather than try to comment on it. We can say this looks like a fibroid, but having some atypical features, and then we need to do further testing. Now, the next feature of the myoma is shadowing. Presence of a shadowing is very reassuring to say that it's a myoma, because you don't see this kind of a distinct shadowing in adenomyosis. So here you can see a myoma, and what the reason why this shadowing happens is myomas are very, because they contain fibrous tissue, you can have, they attenuate the sound so significantly that when the ultrasound beam comes on the surface of the myoma, majority of the sound waves are getting reflected, so you have a distinct shadowing. And the shadowing is so distinct that it happens at the edges of the myoma. And sometimes if there's a calcified myoma, you can see very, very distinct shadowing. So once you come to the edge of the myoma, the ultrasound beam is getting diverted to one side when tangential. So beyond the myoma, you would not see any shadowing, but within the myoma, you have very, very distinct shadowing. So shadowing is a very important feature we look for. Then we look at vascularity. Now, if you look at the normal vascularity of the uterus, we can see the arcuate arteries along the periphery, and then you can see the radial arteries which are coming, and these are fairly regularly distributed. If you set your power Doppler settings to a PRF of 0.3 and increase the gain optimally, you will be able to see the arcuate vessels and also the radial vessels. And the vessels will come and really stop short of the endometrial cavity. But in a case of mid-cycle, for example, and this vascularity can extend into the endometrium also. But nevertheless, in a non-pregnant state, you can actually see this vascularity very distinct. Why I'm saying this is we have to differentiate this vascularity from an abnormal vascularity, which we can see in adenomyosis or fibroids. So the vascularity in a fibroid is almost always circumferential. You can see majority of the vascularity is circumferential. You can also see intralesional vascularity. Now, a few days back, we had a reference saying that I'm seeing a fibroid, but it seems to contain some unusual vascularity. So should I be concerned whether it has undergone a sarcomatous change? Now, that's going to be very difficult for us to say. As long as the myoma has a very, very distinct border and a capsule which is intact, it's quite difficult to differentiate that from a malignant potential. So then why are we actually looking at vascularity in the myoma? It is more to say that there is a capsular vascularity, because this capsular vascularity is what you will not see in a case of adenomyosis. So helping us to differentiate between myoma and adenomyosis will help. This capsular vascularity may help us. Beyond that, we don't routinely do color Doppler of the myoma as a matter of, and report it also. Now, vascularity in a myoma, the circumferential vascularity and intralesional vascularity, you can go through a scoring system, just like as you have a scoring system for ovarian tumors. You have score 1, score 2, score 3, and score 4, both intralesional and, as I said, it's not something which I'm going to act upon. So let's look at this video of a myoma which is seen very close to the cervix. You can see a distinct capsule. Mild heterogeneity is seen. And here you can see an isoechoic myoma. You have to literally strain your eyes to look at it. That's an isoechoic myoma. And then we have just switched on the color. And there is some peripheral vascularity here. And you can see that ring-like vascularity coming down, which is there. So this just tells me, yes, there is a lesion here. And this is the endometrial cavity, which you're able to identify. Right. So then we always measure the myoma in 3 dimensions, as you can see here. And when you do both sagittal and transverse sections, in either of these sections, we will be able to see the capsule quite distinctly. Right. So next, moving on, I'm going to show you a myoma with, you can see distinct shadowing that's happening from the myoma on top. Even though it is small, it is still throwing a shadow. And when you have multiple myomas, we start looking at distortion of the cavity, how much is intramural, and the classification of where it is located, as we had mentioned before. Sometimes the myomas can be very, very big, and you might not be able to reach the myoma entirely on transvaginal. So here you can see the peripheral vascularity brought out very well. And you may not be able to reach. So hence, you might have to use a combination of both transabdominal and transvaginal. Of course, when you have such large myomas with peripheral vascularity, we are not going to have any difficulty in differentiating them from adenomyosis. So let's move on from there to adenomyosis, which is actually an abnormal presence of endometrial tissue within the myometrium. Now, the common features of adenomyosis is, first of all, enlarged uterus, and an asymmetrically enlarged, or it could be globally enlarged. A massively globally enlarged uterus with their endometrial cavity right in the middle, both the anterior and posterior myometrium being hypertrophy can be seen. Or a more distinctive feature will be asymmetrical enlargement. The moment you see asymmetrical enlargement of the myometrium, the first thought that comes to our mind is it adenomyosis? The second thing is called as a fan-shaped shadowing or striped shadows, which are there, very, very distinct, which you'll just see. Then the presence of myometrial cysts. Sometimes myometrial cysts may be the only finding which you might see in a uterus. You may not have hypertrophy of the myometrium. You may just see 2 or 3 cysts distributed, and you still have to raise the suspicion of adenomyosis. Then lastly, of course, is poorly defined endomyometrial myometrial border. The endomyometrial junction is normally very distinct, and we expect a peri-endometrial halo. Now, because the endometrium is growing from the endometrium into the myometrium, you will see disruption of the endomyometrial junction, and that is very, very distinct. So let's look at some of the features here. Here's an enlarged uterus and with asymmetrical enlargement. That's the anterior myometrium, that's the posterior myometrium. Sometimes it can be look quite homogeneous. Even then, when there's an asymmetric hypertrophy, we should consider adenomyosis. And here you can see a globally enlarged uterus and the obvious echogenicity of the myometrium is very different from a normal myometrium, as you can see. And part of the cavity we are able to see, and then beyond that, the cavity seems to sort of disappear. So this is also very distinctive of adenomyosis. Now, abnormal myometrial echogenicity, as we can see, the fan-shaped shadowing. These are called as stripy shadows. And you can see these endometrial glands, which are growing into the myometrium. And that's what gives the very, very typical appearance. Sometimes you may not see any other feature except these stripy shadows, and that should raise a suspicion in the patient. And when you zoom up the image, you'll actually see that these are actually emanating from the endometrium-myometrial junction. Right. So sometimes it is also referred to as rain in the forest sign. Now look at myometrial cysts. The myometrial cysts, as I said, can be very, very tiny, usually distinct with a bright echogenic border, as you can see here. Or you can see a small myometrial cyst. Rest of the myometrium appears to be completely normal. But if you look carefully, the endometrial lining is not very regular in this. And if you look at the third picture, here you can see a complete loss of endomyometrial junction. Here you can see an endomyometrial junction, and then the growing of the endometrium into the myometrium is something which is very, very typical. So if you see loss of endomyometrial junction, if you see myometrial cysts, even if there's one cyst, we still have to suspect adenomyosis. Now, I'm not going to have a very big difficulty between differentiating this between a myoma. The difficulty comes when there's a focal adenomyoma. When there's a focal adenomyoma, then the difference between a myoma and a adenomyosis is only made by the presence of a capsule, which I showed you in the myoma, whereas the capsule will be completely absent in an adenomyosis. Right. So let's finally look at the accuracy of ultrasound in the diagnosis of adenomyosis. The sensitivity of ultrasound in the diagnosis of adenomyosis is about 80 to 86%, and the specificity is about 50 to 96%, overall accuracy being 68 to 86%. This means that there are going to be a certain proportion of the adenomyosis which you're going to miss because you're missing out on the subtle findings which may be there, or it could be the early stage of adenomyosis, which is still not it's still not showing out as typical features which we can recognize. But we also have to say, if there is even significant adenomyosis, the accuracy becomes poorer if there are coexistent fibroids. Ultrasound has a high specificity of 91.8%, but it was less sensitive. It's only 36% or 36 to 37% sensitivity for detecting adenomyosis in the presence of fibroids. So in other words, when we do our reporting, in the presence of fibroids, there's a high chance that you might not be able to differentiate or diagnose the distinctive features of adenomyosis which could be there. This remains a challenge, and I believe it will remain a challenge for a long time, because even if you look at vascularity, adenomyosis will have central vascularity more than peripheral vascularity. Fibroids have more peripheral vascularity than central vascularity. These are some features. But when they are mixed with each other, the fibroids are very dominant. They are dominant because they can grow in size and they can be multiple, whereas adenomyosis is more diffuse. And that's why you have this challenge in differentiating between these two. So what I'll do is I'll stop here and we will take questions if there are any. Thank you very much for this opportunity.
Thank you, sir, for your very enthusiastic talk on the fibroids and adenomyosis diagnosis by means of an ultrasound and how we report it. It was a very elaborative session, sir. Thank you so much, sir.
And that is why I can't see any questions, Dr. Suresh. It was so self-explanatory. I mean, with the diagrams and all, you have taught very, very beautifully the USG findings in fibroids and adenomyosis. Thank you so much on behalf of ICOG for giving your talk in this masterclass. Thank you so much.
Thank you. Thank you. Thank you very much.
There is one question, Dr. Suresh, if you are here, you can answer.
Yeah.
Can you differentiate endometrial cancer versus adenomyosis? Because that was my question on your last picture
Very good.
as well.
Yes, I wanted to mention that actually. I wanted to mention that. So the difference between endometrial cancer and adenomyosis, where there is a loss of endomyometrial junction, is endometrial cancer will have huge amount of vascularity, whereas adenomyosis, the endometrium will not have that kind of vascularity which you see in an endometrial cancer. So this is something that will help you. And also, if you see the zoom up and see the vessels will be completely very distorted, tortuous vessels which will be there in endometrial cancer. And you will not see that in adenomyotic uterus, because it's only the normal endometrium which is growing into the myometrium. Only when it grows into the myometrium, it becomes adenomyosis. So otherwise, the endometrium itself is okay. So you won't see the kind of vascularity.
Thank you, sir. Thank you so much.
Thank you.
Yes, Alka. Let's move ahead. I can't see any more questions. Thank you once again, Dr. Suresh. Yeah.
Yes, so we come to the end of our first session. We will be moving to the next session where we will be talking all about the treatment. So we will begin our session with our very own Dr. Lakshmi Shrikhande ma'am, who will be giving her valuable thoughts and opinion on treatment of fibroid. Is the pen mightier than a sword? So over to you, madam.
My slides are visible, Alka?
Yes, ma'am.
Yes,
ma'am.
I can see Palani nodding. Palani is very happy that there are no technical glitches.
Yeah.
So thank you all. So let us see whether really pen is mightier than the sword. But first and foremost, just some basics. We all know that nearly 20 to 30% of our Indian women in reproductive age group, they have fibroid uterus. And according to our Government of India survey, at any time, nearly 15 to 25 million Indian women, they have fibroid uterus. Types, you all know that these are various types of fibroid uterus. Dr. Basav has already talked in great detail about the palm coin classification, and Dr. Suresh has also touched upon in great detail about the palm coin classification when it comes to L, that is leiomyoma. But when we are talking of leiomyoma, dear friends, you should also be aware of the European Society for Gynaecological Endoscopy, that is ESGE classification. According to that, type O is entirely within endometrial cavity. Type 1, there is less than 50% myometrial extension, and in type 2, it is more than 50% myometrial extension, because this will help you in deciding the treatment modality for that particular woman. Therefore, the FIGO and ESGE system should be used for the classification of fibroids, and pre-surgical classification should be considered for selected clinical situations. Now, why I am showing you these slides, I know you all are very well aware with the symptoms of fibroid, but when we are talking of treatment, the first and foremost goal in a symptomatic woman is to make her free from the symptoms. So these are various symptoms of fibroid uterus. As I already said, management should be tailored to the size and location of fibroids, age of the patient, her presenting symptoms, desire to maintain fertility, access to treatment, and the experience of the treating doctor. So these all are very, very important when you are planning treatment of fibroid uterus for that particular woman. So let us first pay attention to this algorithm. If it is the patient comes to you with uterine fibroid, whether it's asymptomatic or symptomatic fibroids. If it's asymptomatic, you just have to put her under clinical surveillance. But if it is symptomatic, you have to see whether she is premenopausal or postmenopausal. Postmenopausal, you have to investigate her further depending on her clinical situation, her age. You will have to go ahead with endometrial biopsy, other advanced imaging modality, and based on those reports, you will be deciding the treatment. I am focusing more on the treatment in premenopausal woman. So if she is premenopausal, then she falls under 3 categories: whether she wants to preserve her fertility, whether she wants to preserve her uterus, and the third category is patient does not wish to preserve fertility or uterus. So let us see what are your treatment options in the first category, where she wishes to preserve her fertility. We all know we have got medical management in the form of NSAIDs, OC pills, LNG, tranexamic acid, agonists, antagonists, which I will be telling. And the surgical treatment, if she is wants to preserve fertility, Dr. Sunita will be talking about the indications for myomectomy in these cases. If she only wants to preserve her uterus, then again, you have to think of medical management. But in the surgical management, nowadays, you have got many more options like uterine artery embolization, magnetic resonance focused ultrasound, and so many other options. If she does not wish to preserve her fertility or uterus, then also just don't jump to the hysterectomy straightforward. Do offer her uterine artery embolization, magnetic resonance guided focused ultrasound surgery, myomectomy. Yes, of course, hysterectomy is the last resort. So I will be telling you the indications and contraindications in brief about these procedures. First, let us come to the medical management, and these are the indications when you can offer medical management to this woman. That is, she wants to preserve uterus, she is keen for pregnancy, she is not fit for surgery, or surgery is not indicated in that case. So what are the treatment options available to you? As you can see, this is the list of medical management. Then you have interventional radiology, and this is the surgical management which is available to you in your armamentarium. So what are the limitations of existing medical therapy? Now, if you are offering her NSAIDs, then the limitations are lack of supportive evidence, GI side effects, and risk of gastric ulceration. For antifibrinolytics, it is used to treat menorrhagia and dysmenorrhea, but it can increase the size of myoma. What about GnRH agonists? It does have got some side effects in the form of hot flushes. Then the use is limited up to 6 months. Beyond 6 months, we don't recommend the treatment by GnRH analogs, not safe in adolescent population, and the risk of recurrence is always there. Danazol androgens, we are no longer using it in our day-to-day practice. Progestins are also not commonly used. COCs, yes, they are still used as a first line of treatment when it comes to medical management, but always remember that they are also not safe for long-term use and they can increase the size of myoma. So now we are done with the medical management. Now let us come to the uterine artery embolization. Given the current evidence, UAE is not a treatment of first choice for those women who wants to have a pregnancy. Instead, it should be reserved for those candidates who are poor surgical candidates. Now coming to the transcervical radiofrequency ablation, as you all can see in the algorithm, if it is FIGO 0 or 1, she can be subjected to hysteroscopic resection. FIGO 2, 3, 4, that is up to 5, TRFA is an option. FIGO 5, 6, 7, laparoscopic fibroid enucleation can be offered to her. If there is a recurrence, then repeat TRFA if it is necessary, or you can offer her surgery. Magnetic resonance focused ultrasound surgery now is available to our patients. It offers patients cutting edge technology without actually giving any cuts on her tummy, and this treatment involves the application of MRI directed beams of ultrasound capable of heating an area of fibroid tissue up to 70 degrees centigrade and causing destruction through coagulative necrosis. So this is what is FIU. The benefits are there in fibroids and adenomyosis. In there is no scar, minimal post-operative pain, return to work is faster, daycare surgery can be done under sedation only, can be repeated if fibroids recur, there is no scar on the uterus and it avoids hysterectomy. But before offering this particular therapy, as a treating doctor, we should know the indications and contraindications for this modality. So what are the indications? In premenopausal woman, desire to have children and she is symptomatic. In postmenopausal, if there is a contraindication for surgery and if patient is insisting that she wants to have this particular mode of treatment. But age should be more than 40 years, fibroid size should be less than 12 centimeter, number of fibroids should be less than 5. There should be safe acoustic access path to the fibroid. The distance between skin surface and deepest fibroid region should be maximum 11 centimeter. There should not be any suspicion of malignancy. There should not be any acute inflammation. So these are the things which you have to look for. When it comes to contraindication, the absolute contraindications are suspicion of malignancy, pregnancy, acute inflammatory process, and if it is not sufficiently accessible acoustic window for treatment, that is in morbidly obese patient, it is a contraindication. Relative contraindications, if fibroid size is more than 12, fibroid number is more than 5, pedunculated and subserosal fibroids, large scars in the acoustic window, location in the posterior wall or near the sacrum, and general contraindications for MRI or MRI contrast agent should also be considered before offering this particular modality to this particular woman. So I have already told you about the inclusion criteria and exclusion criteria for this MRG FUS. There are various studies which have shown beneficial effect of this therapy as far as fibroid treatments are concerned. The side effects should be known to all. The transitory side effects are seen in 30% of patients and they may experience nausea, vomiting, leg and buttock pain, abdominal tenderness. Less frequent transitory side effects can be seen in less than 10% of patients. They may see abdominal cramping, vaginal bleeding, and less than 3% patients, they may experience first degree skin burns. Very rare complications which are seen in less than 1% patients are second and third degree skin burns, neuropathy, and injury to abdominal or pelvic organs. Now coming to the myomectomy, these are the indications for myomectomy. That is, patient is having menometrorrhagia, she is having anemia, she is having problems of pelvic pain, there are pressure symptoms on the bladder, bowel, there are enlarging leiomyoma, and there is a possibility of neoplasia associated. This is in pregnancy, and ureteral obstruction. So you have to think, if she fits in this category, if myomectomy is indicated, then definitely myomectomy becomes the treatment of choice for this particular patient. But as I have already enumerated the limitations of medical options, surgical options, they also have certain limitations. When it is coming to hysterectomy, of course, there is a morbidity, risk of surgical long-term complications, and of course, this patient cannot have pregnancy in future. Myomectomy, chances of recurrence are there, and you have to keep in mind or tell her about the risk of scar dehiscence in case of future pregnancy. When you are offering uterine artery embolization, do tell her about the chances of fibroid recurrence, pain, possibility of severe complications, possibility of subsequent hysterectomy in 20% of cases, and this modality requires interventional radiologies to complete. Potential ovarian failure, the risk is there, and abnormal placental development in next pregnancy. So now let us divide our patients and see what you should offer. if there is a patient who comes to you with heavy menstrual bleeding, but who do not desire future fertility. So here the treatment is aimed at presenting symptoms, and they are performed in a stepwise approach until the symptoms are adequately controlled. As there are limited comparative studies demonstrating the superiority of one treatment option over another in this category of patients, the patient preference and shared decision making are used to create the optimal management strategy. Now, if there are patients with HMB who do not desire future fertility, remember the first tier treatment for patients with HMB, likely from submucous fibroids, that is hysteroscopic myomectomy, it goes without saying. Submucosal fibroids, according to FIGO classification, we have already discussed 0, 1, 2, the myomectomy. For patients with other type of fibroids that is not exclusively submucous, who do not desire pregnancy, then initial treatment with OC or patch or vaginal ring is recommended. Although supporting data is of low quality, these products, they work quickly and they are widely available, low in cost, and are generally well tolerated. Alternatives that are also considered, they include LNG devices and tranexamic acid and progestin only pills. As direct comparator data are sparse, treatment selection is patient driven in this category and consider variables such as efficacy, safety, tolerability, ease of use, and cost. Consider these when you decide the treatment. Patients with HMB who do not desire future fertility, the second tier treatment in this cases are GnRH agonist and antagonist. You can offer them uterine artery embolization. Again, in this category of patient, treatment choices is based on patient preference around side effects, invasiveness, and recovery. Of course, the other deciding factors, they include availability and cost. The third tier treatment in this category of women include focused ultrasound energy, which I have already discussed in great detail, and in rare cases, endometrial ablation. These provide less invasive therapies for patients who desire less time away from work and they want uterine preservation. Procedure selection here is determined by patient preferences around invasiveness and recovery time, as well as treatment availability. Now the patients in this category of women, the last line of treatment for this woman is, of course, hysterectomy and myomectomy. Patients who come to you with bulk or pain symptoms but who do not desire future fertility, in these cases, you can give them option of GnRH analog and UAE. Patients and clinicians, they must balance the hypoestrogenic symptoms associated with long-term use of GnRH analog with the procedure risk and longer recovery of UAE. So you have to consider and discuss the pros and cons of both the therapy with the patient. If not effective, or if patient desires more definitive surgical therapy, then myomectomy and hysterectomy are the options for her. Selection of medication, embolization, or surgery depends on patient preferences around side effects, invasiveness, recovery time, need for prolonged treatment, and risk of the treatment compared with risk of symptom recurrence. Patients who desire fertility, they are most medical therapies we don't advocate in this category of women, and here you have to consider the myomectomy depending on the size, location, and type of fibroid. Dr. Sunita will be covering this aspect in great detail. So for patients desiring pregnancy who have symptoms caused by FIGO 0, 1 or some type 2 hysteroscopic myomectomy, symptoms typically include abnormal or heavy uterine bleeding in this type of classification of leiomyoma, and hysteroscopic myomectomy is minimally invasive, provides relief of symptoms, and it typically preserves the integrity of the myometrium for future pregnancy. For patients desiring pregnancy, wishing to maximize fertility and presenting with submucosal fibroid in the absence of other symptoms, again, hysteroscopic myomectomy is recommended. This is grade 2C evidence, and support for this approach mainly stems from the minimally invasive nature of the procedure and anticipated benefit from removal of fibroids that impact the uterine cavity. For patients who are desiring pregnancy but who have bulk symptoms with or without bleeding or fibroids that are not amenable to hysteroscopic resection and in whom there are no major contraindications to a surgical approach, then these patients can be offered abdominal or laparoscopic myomectomy. Myomectomy is preferred over UAE and focused ultrasound surgery given the lack of information about the safety of pregnancy with these two approaches. For patients undergoing myomectomy in whom laparoscopic removal is technically feasible and who have access to a surgeon with advanced laparoscopic skills, a laparoscopic rather than open myomectomy is recommended. However, the integrity of uterine incision during pregnancy after lap myomectomy has not been evaluated adequately, and it may be inferior to open abdominal myomectomy. So friends, in short, this is the chart which is comparing the recommended therapies for uterine fibroids, the advantages and disadvantages of each therapy. As you all can see, when you are talking of GnRH agonist, is definitely decreases the blood loss, operative time and recovery time. But the disadvantage is long-term treatment is associated with higher cost, menopausal symptoms and bone loss, along with increased recurrence risk. When you are talking of LNG-IUS, definitely it is most effective medical treatment for reducing blood loss. It decreases fibroid volume, but the disadvantage is irregular uterine bleeding and increased risk of device expulsion in cases of bulky uterus. NSAIDs definitely reduces pain and blood loss, but it does not decrease the fibroid volume and it can have GIT side effects. OC pills, they do reduce blood loss, ease of conversion to alternative therapy if OC pill is not successful, but the disadvantage of OC pill is that it does not decrease the fibroid volume. Selective progesterone receptor modulators, now we are having ulipristal acetate, which is available 5 milligram tablet, but the advantage is definitely there. It decreases blood loss, operative time, recovery time, not associated with hypoestrogenic adverse effects, but there are disadvantages with this mode of therapy in the form of headache, breast tenderness, then associated endometrial changes, increased risk of recurrence. Tranexamic acid reduces blood loss, but it does not decrease the fibroid volume. Hysterectomy, of course, it's the ultimate treatment where patient is cured, I will say, that there is no more risk of recurrence of fibroids. When you are offering her magnetic resonance guided focused ultrasound therapy, advantages are there that it is non-invasive, shorter recovery time with modest symptom improvement, but disadvantage is that patient can have heavy menses, pain from sciatic nerve irritation, and higher re-intervention rate. If you are offering her a myomectomy, then yes, preservation of fertility is there, but the risk of recurrence is to the tune of 15 to 30%. And when you are offering her uterine artery embolization, of course, it is minimally invasive, avoid surgery, shorter hospitalization, but recurrence rate is there around 17 to 20%. And there is a post-embolization syndrome is also you should be careful about. So friends, when it comes to treatment, this is the final slide. It all depends on the patient characteristics. Asymptomatic woman, just clinical surveillance. Infertile woman with distorted uterine cavity, myomectomy. Symptomatic woman who desire future fertility, medical treatment or myomectomy. Symptomatic women who do not desire future fertility but wish to preserve the uterus, medical treatment, myomectomy, uterine artery embolization, MGFRUS is there, and symptomatic woman who wish to have a definite treatment and is not interested in future fertility. Of course, hysterectomy is the treatment of option in this category of women. So what to choose, friends? I have already told you, it has to be tailor-made and it depends on so many factors. Your own experience, accessibility to the patient, the cost factor, affordability also comes into place. So it has to be a tailor-made treatment for each and every woman who is coming to you with fibroid uterus. So thank you so much for your patient hearing. If there are any questions, please post in the chat box.
Thank you, Dr. Lakshmi Shrikane. That was fantastic and phenomenal. And that's why we gave the question to the topic to the chair, and the chair did absolutely phenomenal. And so that was the standard of raising standards of ICOG. And thank you very much. That was absolutely a complete message given to the audience. And I'm sure we'll have questions to go on. And meanwhile, let me ask Dr. Alka to introduce Dr. Sunita, and we will go on to the topic, and I'm sure Dr. Lakshmi will be happy to answer questions, though there are questions already in the chat box.
I'm very happy to invite our next speaker for the session, Dr. Sunita Tandurwalkar, ma'am. She is the head of the Department of OB/GYN and Chief in IVF and Endoscopy Center, Ruby Hall Clinic, Pune. She is an advisor and consultant in Dr. D.Y. Patil IVF and Endoscopy Center, Pune, founder and medical director of Solo Clinic IVF, a center for excellence in infertility, Pune, founder and medical director of Solo Stem Cells, a stem cell research and application center, Pune.
Alka,
yes, sir.
She says don't want that much of introduction. She's
okay,
humble to say that. Let me only tell one word and let Dr. Sunita start. She's consultant at Ruby Hall, and we all know that's why the ruby color dress on the photo and the ruby color dress on the live as well. And she's going to be doing myomectomies without the ruby color, without the blood. That's what is going to be the moral of the topic today. And she's a phenomenal speaker, phenomenal surgeon. And without wasting time, let me ask Dr. Sunita Tandurwalkar to go on and speak to us and say, oh, is lap myomectomy always possible, or there are any situations where she's not going to be able to do it and she's going to open up and things like that. So putting such tough questions to the diamond questions to the Ruby lady. Over to you, Dr. Sunita.
मिताली प्लीज उनको अनम्यूट करो, को-होस्ट बनाओ, डॉक्टर सुनीता को बनाया?
Yes, ma'am.
Yes, Sunita. You are still not co-host? No. Mitali?
बनाया मैम.
अनम्यूट यार, मिताली कब से अनम्यूट बोल रही हूँ.
Unmuted, yeah.
You won't imagine, I'm on my way to Nagar for installation of the team. I saw the tower and I heard Sujata ka so much of a problem. I told my driver, tower hai, yahan ruk jao, we will get the range. Only thing is my topic, I made an endoscopy. Myomectomy, can it be done always? Allow me to speak that. That will make a big difference. First of all, you know, the way Lakshmi covered, I felt like I have relearned many things. Fantabulous collection of, I need this lecture, Lakshmi, beautifully, very well read, very thoroughly studied for everyone. You know, this is what the ICOG chairperson is supposed to do, and they're supposed to send us also the lectures. Amazingly. My topic has become very simpler. Everyone learn now how to diagnose and when to remove and when not to remove. Everything is crystal clear in mind of all. Thank you, dear all, for giving me an opportunity to be with you all. I always say, advances in science is always for the betterment of a human being. And in science, it is very important that we modify our ideas so as to move with our treatment. What we used to do 3 decades ago and what we are doing today probably changed a lot, not only in the way we operate from single chip camera to 3D and robotic, but also the way we diagnose the myomas, the way imaging technology has evolved, helping us to do the way we want. Myomectomy, can it be done always by endoscopy? Before I say, friends, first is you should know, and after Lakshmi's talk, it has become crystal clear, remove or not to remove. We all have to understand that whenever it was a doubt, it was cut it out was the dictum. Whether the removal, it depends upon size, number, site, relationship with the cavity, everything we learn now. So we have to make efforts for a mapping. Now, submucous myomas, why I want to take endoscopy? Because Palani, third lecture is not hysteroscopy in myomectomy. Na? 1 minute. No, it is you who is speaking adenomyosis. So that's one. So because many of the fibroids we remove by hysteroscopy also. Now, submucous myoma and certain intramural cavity compressing myomas we do remove by hysteroscopy. So type O, type 1 is more than 50% projecting. Type O is 100% in this, and type 1 is less than 50% projecting. Now, we remain innovative throughout the way we work. Age-old technology, if it is a type O, we used to do the resection like this. But now, what we do is, we just take a scissor and cut it out. You just go to the base with the scissor and chop it out. 3 centimeter, 4 centimeter myomas, they will undergo disintegration and they will dissolve. Put the patient on antispasmodic for 2-3 days. Well, submucous myomas like this, whenever you say, always remember, you will tell the patient, I may need 2 sitting. Always under promise and over deliver. Never over promise and under deliver. That spoils our reputation. Now, whenever we have such a submucous myoma, which is type 1, we resect. Now, we all have a rigid telescopes. So the cavity, it's going in a depth. You need to be little tactful. I'm trying to hook that out, but it is not possible to hook. Then I will take more pieces out. But these I will take just 2 to 4 millimeter thickness so that I'm not damaging the basal endometrium. You can see I'm doing a hydro massage. What is hydro massage? Making intrauterine pressure changes with either decreasing the flow or making the outflow on off. With that, you expect the myoma to get loosened up from its capsule and then come up, and then you can start resecting that myoma which is bulging now. I know that I will be superficial and I'll be taking that out. Sometimes you need to be creative. This is less than 50%, but it is hardly between 2 to 3 centimeter. If you see very closely, I have used the loop to resect the top. And once I resected, it's like putting your finger, instead of inserting a finger, I'm inserting the Collins knife. This is a very old video of mine. Today we have a myoma screw, but I feel Collins knife of 4 mm is more turgid than the myoma screw. And myoma screw, it's difficult sometimes to come out from the posterior wall. From the fundal wall or the anterior wall, it is much easier, but from posterior wall to dig it out becomes difficult. So this Collins knife, you can just poke in and take out. Look at the shining capsule and the crater down. You have not damaged the basal endometrium at all. Now you feel that this crater is too big. You take out your telescope and go in again, and you will see that that crater disappeared. The myometrium contracts immediately and it becomes a wall. Now, this is the myoma. Ideally, I can call it either intramural compressing or type 2 submucous myoma. And that is why I have taken both the hysteroscopy and laparoscopy combined. Now, how will I decide? If you see the serosa, first the diagrammatic representation, serosa is so thin out. I will not like to do hysteroscopically in this case. I will go laparoscopically and I will just take an incision. Now you see here, my sonologist told me on a right lateral wall, there is a bulge, while in left lateral wall, no bulge. I go in, I exactly get the picture. The bulge on a right lateral wall, I take an incision, I took out the myoma. Always I remain intracapsular, so I don't open the cavity. I'll be showing you with the video. Now, sometimes, yes, we do feel the challenges and we should be thankful for it because that builds our strength and a character. Now, look at this large submucosal myoma. Is it possible always? I was given a topic, myomectomy. Is it possible always to do endoscopically? Now, endoscopic means either by hysteroscopy or laparoscopy. This is a type O submucous myoma. One is justifiable to do this myoma completely with the laparoscopy. Can you see that it is 10 centimeter? So you will take a lot of sittings, 2 sittings, 3 sittings to remove that. Instead, you can go laparoscopically, take a incision and remove that myoma. But this patient was from Saudi Arabia, unmarried girl. They become grand multi. I don't wanted such a big incision from anterior fundal to posterior wall. So I told them, if you're ready for 2-3 sittings and staying in India for 1 month, I will do. This is my old video of 2004 when we used to call it as a mini hysteroscopy. Today we use the word office hysteroscopy. This is a 2 mm Versa scope, which has come even before the Bitochis by Storrs people. Johnson & Johnson had come out with this 2 mm Versa scope, and I have selected the myoma all arising from right lateral wall type O just for the fun of it. Now, why this office hysteroscopy? It is to confirm your finding, and now near 50% I'm showing you unedited, which is just 1 minute. Now, mentally you are prepared. I'm not closing the loop. I'm going beyond the myoma and I'm resecting, going beyond the myoma and resecting. So I'm taking out 10 centimeter pieces. Now, why this is important? Because your speed of surgery matter. Can you see this open vessel channel? Even if you are using bipolar with normal saline as a fluid for distension, fluid overload can happen. You can wait at 1.2 liter. At the most, you can give a Lasix and have an intraoperative catheter so that at the most you have a Lasix, you can give 10 Lasix and the catheter in, so that little bit 200-300 cc fluid overload you can allow. But what I want you to observe here is so many pieces are coming in your way. Don't waste time in removing. Keep on doing. We have done office hysteroscopy. We did our inspection. We know entire this area is nothing but the fibroid. When you keep on moving, you realize with your hydropressure, all these pieces move out. Can you see that? I have unedited video and I'll show you the glance now. More than 50% cavity is out, long pieces I can see. And then I take a right angle turn and I keep on doing as fast as possible. The time when anesthetist says, please stop it, you are supposed to stop. This is the only case probably the surgeon should not dominate the anesthetist and should listen to them. If they say fluid overload difference, it stop. We were fortunate to do this case in one sitting because we wanted to make some record. Now, these are the multiple myomas. Again, few people I have seen, they are doing it laparoscopically. Is it possible? Yes, it is possible. But I will always go for hysteroscopy for submucous myomas. Now, second question, someone can ask, can I give a GNRH so that I'm more comfortable? The sizes will be less, the vascularity will be less, and it will be easy to operate on. I will say strictly no, no, no. Why? Because if you see now, I'm going closer to the fundus. Can you see this 2 millimeter, 4 millimeter, 10 millimeter myomas? They will disappear with your GNRH. And then when after 3 to 6 months, patient will come back with the recurrence to you. This is, I can't show you so many videos. Go on my YouTube channel. 30 myomas, one after the other, I removed without taking out the hand. It's an unedited video available there. Subserous myomas. When it comes to infertility, we don't need to operate on them. But can it be done laparoscopically all the time? Of course, it can be. I'm going to show you only one video of it. 44-year lady. She had these multiple myomas of 25, 30 centimeter, 20 centimeter, and another 18 centimeter. Now, if you see more carefully, this patient was from US, came to me for laparoscopic surgery because they advise her open surgery. Now, she was supposed to undergo embryo transfer over there. And can you see in the center, 1.5 centimeter white polyp. I sat with the patient. I explained her that I will try my best to do laparoscopically because I found they are pedunculated. My sonologist gave me a beautiful diagram of a pedunculated myomas, and I know I can remove. Can you see that? This is 30 centimeter was pedunculated, 20 centimeter was pedunculated, and this 10, 14 centimeter posterior wall I can remove. But the rigid telescope to pass for a hysteroscopy and remove the polyp, it was 15 centimeter from the external os to the fundus. And I told her I won't be removing it because I'll be struggling. This os is not visible on a perspeculum. The uterus is all taken up. I will just tell her. Now, why it is important? Because the US people will tell you, doctor in India removed myomas, but the most important thing, culprit in a fertile implantation is the polyp they did not remove. If my patient is aware that, yes, I have a polyp and I have been told now they will not be removing for obvious reasons. Now, how do you prepare yourself? First is, can you see the ergonomics is different? Here it is 30 centimeter up to the hepatic junction and 20 centimeter up to splenic. So between these two, I will go here. And my primary port, I'll go here. And then I will come under vision secondary ports. So your little bit, your logistic, your hand movement, you need to prepare your mind. Don't clutter too many complicated cases on one day. This is the point with I went and then I put mine. Now, once you go in, don't jump for the surgery. Do the thorough inspection. Confirm your preoperative findings. So associated, this endometriotic spot is fine, but you can see the fibroid is dangling. It means it is. I will not be able to see the upper wall because I myself is at the zypisternum. But I'm seeing that I was told 10 centimeter pedicle, and this is also 10 centimeter pedicle. So my life is simple and I know I will be doing this job perfectly. How do we go for laparoscopic? Why it is possible? It is pedunculated. I will just put 2 loops and I'll close down the pedicle so that when it is a 5 centimeter pedicle, definitely you can obstruct. Don't cut on the cirrhosis of the uterus. Keep 2 centimeter margin. You will encounter a lot of big vessel, but the bleeding will come is all entrapped blood from the myoma, not from the patient's side. Then you go for the second. Now 10 centimeter, don't expect it to get obliterated completely, but the miniature of the vessel will definitely be decreasing and you will be able to do good job. Again, cut on the myoma lower 1/3 and not on a serosa so that you got a wall to suture that. You can see the loose loop also over there. Once you remove these 2 myomas, then you get to see the third myoma. How do we do myomectomy? Myomectomy is always incision, enucleation by traction and counter traction. All the big vessels which come in the way, you should be just closing them. If you remain in a very good plane, it is usually avascular and always cauterize on the myoma, never on the myoma bed. As soon as one myoma is out, you should suture that so that before the vasopressin action goes off, you can. So this is actually fibroid number 3, not 1. Whoever has done the fellow for me, they have done little bit this print mistake. This is 30 centimeter and this is a fibroid number 120 centimeter. It's very important that you go determined and do the good job for you. More difficult is the morcellation and taking out. Now, intramural myomectomy, myomas impinging on the cavity. This is how we do the mapping of those pathology. And seeing this pathology, I decide whether it is possible. Usually 99% it is possible. Friends, initially your inclusion criteria may be less and exclusion may be more. As you grow with your experience, then your inclusion criteria widens and exclusion criteria decreases, and you start doing more complicated cases. It is same for everyone. There is a learning curve. Now, why this mapping helps me? This is, for example, I'm showing you with the arrow, the central. How to take the incision, it doesn't depend upon anterior or posterior or how. It depends upon first priority is always the myomas, how they are situated. I will see to it that the cornues are not affected. Now, in this case and this case also, can you see 2 large anterior wall and many posterior wall? Same is here. I will take one anterior incision and take out 1, 2, 3, 4, 5, 6. I will take out one incision and take out all. Also, for example, sometimes these are the large myomas. These are bigger myomas. I'm not bothered while taking them out because I'll be fast because they are miles away from the cavity. This blue line, curved line is a cavity. I think my arrow is here for those who can't see. And this myoma is compressing. Now here, I will also explain the patient, your posterior wall, the small myomas, then neither cause bulge on the wall or in the cavity, and I'm not going to take out, while these remaining 5 I'm going to take out. If you do very good preoperative counseling, which I do with this patient in the consulting room, and the fellow who has been standing with me when I'm teaching or explaining the patient, the same fellow has to wash up and the same fellow shows the video to the patient. So what you explained and what video is showing, if it is the same, that is a transparency, and that is where you win the heart of the patient and the faith of the patient. Ultimately, it is the faith which works for you. So how do we do endoscopic? 3 large myoma. I have kept a picture in picture there. Not large actually, these are medium size, 3 to 5 centimeter myoma, but they are not causing much bulge. They are compressing the cavity. Now, what I will do is intracapsular. It means I will cut the capsule and make the myoma naked, and I will give a traction and remove. Myoma 1 is removed. Vlog has made our life simple. If you are fast within 20 centimeter of a vasopressin action, the bleeding will not be there and you close down. You take the complete thickness of a wall and then the serosal surface with always baseball technique, that is always inside out, inside out. Now, I have always counseled this patient that if your myoma, I open the cavity with the taking out of number 1, and even with the 2, then I will not remove the 3rd because you will land up in intrauterine adhesion if I open the cavity from all sides. Now, if you don't explain, and if unfortunately you open the cavity, then patient will say you did not remove because you don't know how to remove it. Here, both the times the cavity was not open, I'm relaxed and I will go for the 3rd myoma. But since you have counseled the patient, you are stress-free while operating. By chance, if it opened up, you don't have to worry about it because you have told patient, then you will do it after 2 months. This is a shining capsule and you remove it. Sometimes, now these are the cases. How do I remove these myoma? If you see, this is the myoma, which is more of a intramural compressing or submucous myoma, you can say. Now, ideally, I should go remove this submucous myoma by hysteroscopy and the job is done because the other intramural myomas are not coming in the way. But when I sit with this, now imagine I have removed this hysteroscopically and patient did not conceive in 6 months. These 2 myomas which are there, they will travel the path of a least resistance, and that is towards the cavity. And this middle fibroid will become then submucous type 1 or type 2 myoma, and patient will need another surgery. So this mapping helps you tremendously to think. Only thing is you need to think. I remove this myoma, patient doesn't conceive, the path of least resistance, the myometrium will push this myoma in. Your thinking has to go in so much of a depth, and I will do laparoscopically, and one after the other, I'll remove all the myomas. I'm skipping this video. This is another myoma. Very simple. I'm just trying to show you different energy sources. This was oblong, anterior wall. So what I will do is first, when I go first thorough examination of the myoma, important to confirm your finding. And then because it was oblong, I will take small incision, not a very big incision. This is a ligature, friends. Ligature, Ensil, Thunderbeat, these are the vessel sealing energy devices. First instruments to buy is a very good bipolar and monopolar. Only when you progress, then get harmonic. And then you have more money. You don't want to spend on your cars and your personal thing, which I believe every endoscopic surgeon should invest into the machineries. These surgeries, can you see this monopolar hook I'm using? This is probably while demonstration. I wanted to show that it's not the instrument which makes the surgery safe. It is the surgeon who can use this instrument wisely to make the surgery simple and safe. What I'm doing is I'm giving a small cuts so that the capsule is out, and I am seeing a shining myoma, traction and counter traction. I will remove this myoma just. So the one person is sitting down with the Ellis and the other is pulling with this. Now this myoma, I was told that it is an oblong myoma, and you will see that it is oblong myoma. I'm removing that myoma completely. So friends, it's important that sometimes anterior wall taking vertical incision becomes easy. If the corners are not coming in the way, always anterior wall, I take vertical so that both the walls are exposed beautifully and I can take a very nice obliteration of the space. But posterior wall, I go for a horizontal incision because that becomes easy with my ergonomics of the instruments, because I'm ipsilateral. But most important thing is you should see how I can preserve the corners of the patient. Not necessarily these patients are for IVF. Your end result has to be the excellent pelvis, good tubo-ovarian relationship, clean pelvis, and all these infertility patients, and even those who are affording and not infertility, where they wanted me to do myomectomy, I will always put the work, what you call that, intercede, because it definitely prevents the adhesions. Your end result should be such a clean pelvis. Sometimes it is compressing from anterior wall in a different, now the same case from the fundus to the anterior wall. Can you see that? If I go back here, it is compressing completely posteriorly. I will go and I'm examining. Now here I am taking Ensil just for a demonstration and a horizontal incision. I try to take the different surgeries and different methods for the same type of a tumor with the different energy sources. Now, why I'm taking horizontal? Because I was told that this is very vascular, large vessels. So when I take a horizontal, I will be cutting less vessels. I'm just going ahead because there's no point in showing traction and counter traction from the fundus to the isthmus. I will not cauterize, never cauterize. Can you see this is a capsule? So if I'm within the capsule, there's no question I open the cavity. You can see at the left lower edge, there is a bleeder happening. I will never cauterize. Cauterization, necrosis, infection, hematoma formation, all these are the triads which cause weakening of the scar. So take a multi-layer, good obliteration, no hematoma. Don't cauterize, no necrosis. So these are the various myomas you get over the period. They are different sizes, different shapes, different positions. You should know how to remove it. Now, for example, this myoma, it's completely obstructing the one corner. Someone told this patient that you remove the fibroid, you will conceive. She came to me for laparoscopic myomectomy saying that, madam, you remove this myoma so that I'll conceive. I sat with her and I explained her, my dear, if this fibroid is the culprit, you have contralateral tube and ovary, which are normal, which are not compressed. You should have conceived from that side. Definitely this fibroid is at the corner, but I will not say fibroid is a culprit unless I remove the fibroid and within 6 months you conceive naturally. Then I will say, why this is important? Because if you do the myomectomy, considering she came to you, ready-made, you got the case, you do the myomectomy and she doesn't conceive, she will come and eat your head. You remove the myoma. I did not counsel that myomectomy is going to give you a fertility back. I told her, if you conceive, fantastic. If you don't conceive, then fibroid was not the cause. Otherwise, you would have conceived. So always play safe, under promising, over delivering. Now here, what care I should be taking? Can you see this fibroid is compressing? I'll go to the lowermost edge. If you see my incision, I will go as low as possible. See the end result in 4 diagram. Where is the cornu and where is my incision? My incision is nearly 4 centimeters away from the cornu. This is what is very important. Ensure that your end result is not damaging the cornu. So prepare yourself well before each surgery to excel your intraoperative performance and believe in chasing the excellence every day. You can't say 3 decades, I'm doing it, it's okay. One day I have a complication. For that patient, it was 100% complication. Please accept every day, enter in the operation theater with the same enthusiasm and with the same tremendous care as you have entered in a first day of your operation theater. Same precautions I take even today as if I'm operating for the first time. Now these myomas, can it be done laparoscopically? Let me go back. Now these myomas are 20 centimeter to large anterior wall. Together 30-40 centimeter makes no difference. Now this patient has come for a myomectomy. Obviously, I thought these two, and I told her in a complimentary, I'll remove this posterior small tingo also. She said, look, doc, I did not come for you for these 3. I came for these myoma as well. Now, for me, it is not causing bulge outside, inside. So I told her, no, it is not possible because there is no bulge. She said, I don't know that. I want that also. And friends, I like to pamper. All the fellows here, I'm telling you, pamper your patient as you pamper your mother or a sister. Love them. You will get love back. What you give, God gives you back. I pamper, I take care of my patient tremendously. I'm showing just the monopolar hook for the large myoma. If your speed is very good, within 20 minutes, vasopressin action, it becomes bloodless, suture it off. Once you suture that, go for the next myoma and remove that myoma also, bloodless, you done. Only when you remove these 2 myoma, now you can antivert the uterus. And now I can see this bulge, exactly what I was told. I took out between the 2 cornu, you have that. When my patient wanted the 4th one, I gave a call to him, asked, where is the exact location? He said me, go 2 centimeter below and 2 centimeter to the left. Can you see that? I removed that myoma, I closed with the simple suture, and I tried to palpate. I could not feel anything. I just boldly took an incision and pressed my forceps there, and I could see the myoma bulging out there. That's your faith on your sonologist, and that's where you did. My patient was more happy for that 2 small myomas than the large myoma, because she knew now there are no more myomas remaining inside. Sometimes this is a 30 centimeter myoma. Is it possible to do laparoscopically? Yes. Is it possible? But always take a consent for open. I take a consent for open even for a 5 centimeter myoma and 3 centimeter myomas also. Why? Because you never know what you can land up in a complication where when you might have to open vascular injury at the entry. You never know what can go wrong. Never be overconfident. Be confident, be realistic. Explain the patient that I'm going to do laparoscopically, but you need to give me a consent because you will be under anesthesia. In case if I need to open, your safety is my priority, not doing at any cost by laparoscopy. So what I thought with this is, with my fellows previous evening, we like to sit with these videos, with this mapping. We decide the sequence of a surgery, the energy sources also to be, and how I'm going to do it. So here, instead of taking a central incision on the anterior wall, if I take a U-shaped incision and remove the redundant anterior wall also, I don't have to go in a depth. So we decided, let's see on a table. Left side cornu I saw, right side cornu I saw. They were exactly how I expected. And this is a white rangoli with the monopolar I draw. If I have to take a central incision, I need to do so much enucleation, and then I have to do such a closure, 10 centimeter closure of that bed in 4 layers. If I take a U-shaped incision, keeping 5 centimeter from all, I can nicely close the anterior wall and the corners will not be damaged. So I decided to take a U-shape. The ideas, the creativity comes when in the night you are sitting with the pen, pencil, with this diagram in front, what I can do differently. Friends, for us as a gynecologist, same hysterectomy, same myomectomy, same ovarian cyst every day and same cesarean. Try to do something innovative, different, creative, and then you can perform. As again, if your speed is very good, it becomes a bloodless and we could take out that flap and we could do a beautiful surgery. Never leave the chance to see the pouch of Douglas associated endometriosis over there. What is very tiring and exhaustive is morcellation. Probably this is my last video. Can I do this laparoscopically? Now, this patient had multiple myomas. Endometriosis operated, laparoscopy, no. It was open surgery, one more surgery for myomectomy, and came to me for IVF. We did a frozen embryo transfer. I created her embryos. Sometimes when I see that, I feel so scary. The ovaries were so deep inside and we did it. Now, before the embryo transfer, I need to remove her fibroids. There were 3 intramural myomas. I can't see even uterus, forget about myoma. So your adhesiolysis, the only energy source is no energy source. Just take the more bits on the uterine wall than on the bowel. Gently pull. More, you should push the uterus than pulling the myoma. Allow the serosal surface to go with the bowel, no problem. But I started seeing some part of a myoma. Don't jump for that surgery. Because you will do myomectomy, you will not have a flap to close, the posterior flap, unless you make the complete uterus naked of this adhesion. So what I'm doing is I'm taking out, I'm just moving little fast forward for the time. Can you see that? Completely adherent rectum over there. I'm going to take small bite, fiber by fiber. Now she had associated hydrosalpinx. We all know that hydrosalpinx has to be excised. I'm opening the lateral pelvic wall just to see where the ureters are. I'm not opening for a uterine. Once I confirm, could you all see where the ureters are? I'm just going deep down, whether it is on there. And you can see that the ureter was completely on the left lateral wall. And that's why from medially, I was not able to see. Now I'm doing excision. I know the ureter is miles away and I excise that hydrosalpinx. Only then, now I will be able to see the uterus with the myomas. Now this is a myoma number 1, I'm taking out. Then the myoma number 2, I'm taking out. And then the third one was to the right lateral wall. So instead of going from a posterior, I went from a virgin area and I removed that third myoma. There is no bulge, but you have to believe your sonologist told you that myoma was completely compressing the right lateral wall. I will go in and I will dig for the myoma. And that's how we remove that myoma. Such a big myoma, you leave, whatever surgery you have done, her FAT will not be resolved. So this is how, friends, myomas come in various sizes, shapes. Believe me, the central piece, myoma, very simple. It is away from the cavity. I'll just go in and chop, chop, chop. You will remove. When the uterine walls, they are compromised. The cavity is like these curvature. These are the difficult myomas. Can you see? There are so many such cases. I have thousands of such photographs with me. Art of endoscopy lies in the imagination of a surgeon. Surgery, this is very important. I always tell, imagine the surgery. Simulate the surgery previous night so that you have to just perform. You have done the rehearsal, how you are going to do. You have to just perform so that you will perform best. But surgery at any age group is uncomfortable. As a surgeon, your job is to make it comfortable. So first is find out whether it is a culprit, whether it is causing subfertility, as Lakshmi has explained to us, when and which myomas to remove, and then only. Some women need to be treated, others can't or don't. Important is find out which one. Friends, in infertility, individualization of each case is important in order to ensure excellent results. I know this is an educational platform. I don't want to say anything. One thing I want to say, don't stop when you are tired, stop when you are done. And that is why I'm traveling to Nagar, because I'm not stopping, I'm unstoppable. I want to go for this presidency election, friends. I know many of you may not have the voting right, but definitely you can bless me. Your blessings are very important. And I always like to thank my all fellows and consultants with me. They are the reason why we are successful. They do it so beautifully, the preparation, the in pre-op, intra-op, post-op, they sit with me and they are the reason why I can perform. I'm immensely thankful to each one of them. Thank you. Thank you.
Thank you, Dr.
Mesmerizing
Sunita.
talk,
Thank you,
Sunita.
Lakshmi, for a golden opportunity.
No, as always, it was a mesmerizing talk, Sunita. Everyone can see your passion for endoscopy. It was palpable everywhere in each and every slide, your videos, and I know you are a fantastic teacher, a great academician, and a orator par excellence. We learned a lot, Sunita, from your talk.
Thank you. Thank you. Thank you, Palani, and thank you, Alka. Any
Thank you
Thank
very
you
talks?
so
much.
much, sir. Thank you so much, ma'am.
I don't see any question. Unmute me ke baad there is nothing. So I feel that's
No,
fine.
there are questions for you as well. There should be questions. Yeah,
Oh.
no, you will have questions now. Now you will have questions.
Okay, we can move on to your talk and then we take, no problem for me.
Alka, let me share my slides, Alka.
So sir needs no introduction. Sir is our beloved professor from Sri Ramchandra Medical College and Research Institute. And he'll be talking on adenomyosis, not an enigma.
Allow me to share my slides.
Yes, please.
Seeing my slides?
Yes, we can see. Make it slideshow. Yeah, it's gone.
I'm just checking. You're able to see my slides now?
We
No
saw
more?
it, but it has gone now. Your
Yeah.
screen. Yeah, we can see.
I love to hear Palani.
Yes.
His slides, his comments, they are always so beautiful.
Thank you, Sunita. Speaking after you is difficult. Anyway, let me try and see whether I can match. It's very difficult to speak in this forum. Thank you very much for this opportunity as well, Dr. Lakshmi. And adenomyosis, is it an enigma or will it be cured or we don't know? It's always an enigma.
பரமசிவன் கழுத்தில் இருந்து பாம்பு கேட்டது கருடா சௌக்கியமா யாரும் இருக்கும் இடத்தில் இருந்து கொண்டால் எல்லாம் சௌக்கியமே கருடன் சொன்னது அதில் அர்த்தம் உள்ளது.
Oh, the song says the snake on Lord Shiva's neck. Oh, it's fantastically sitting and giving its own blessings to everybody. Garuda asks, are you fine? The snake says, wherever we are, if we are there, we are fine. But if the snake comes down, the eagle will take care of the snake. So, ladies and gentlemen, that is what is adenomyosis. The endometrium has to be within the endometrium. If the endometrium breaches and goes to the myometrium, or it produces adenomyosis, then that would be the everlasting dogma. And whether we'll see that is the enigma or not is going to be the next 15-minute talk. Intramyometrial presence of endometrial mucosa, which is glands and stroma, surrounded by reactive hypertrophic myometrium, is the adenomyotic lesion. Oh, now the talk for the next 15-20 minutes or 15 minutes would be Brahma, Vishnu, Shiva, the Trimurti. How are they going to help us in managing, diagnosing, and treating adenomyosis? Brahma, the creator. So how did he create adenomyosis? Macroscopically, adenomyosis, we need to have changed definitions, and that is the enigma which I'm going to solve today. Globular and cystic enlargement of the myometrium with some cyst filled with extravasated, often hemolyzed RBCs and siderophages. Microscopically, ectopic endometrium must be located past the last glans of the basalis. It is circumferentially surrounded by bundles of hypertrophic smooth muscle cells called collars, and that is how you need to confirm that it is adenomyosis. Oh, sometime back, the old heritage, 40, 50 years back, when the 25, 30 years back, when we were all postgraduates, a 40-year-old menorrhagia, dysmenorrhea lady, always bulky uterus with NSAIDs, antibiotics, so seen by minimum of 3 consultants before, fed up and finally planned for a hysterectomy, and the biopsy report will finally come back as adenomyosis. So until then, we won't even know that it is adenomyosis. This was 25, 30 years back then. But it is
அன்று வந்ததும் இதே நிலா என்று வந்ததும் அதே நிலா என்றும் உள்ளது ஒரே நிலா இருவர் கண்ணுக்கும் ஒரே நிலா.
Ladies and gentlemen, adenomyosis was even existing 25, 30 years back, but we did not see that. This was present then, ever, and even now, and we will see them always, but we did not diagnose them properly 25 years back. And how were we diagnosing adenomyosis sometimes back? How have we changed now? The symptomatology has differed now. 35% of adenomyotic ladies are asymptomatic. Please get that clear. 50% of them have menorrhagia, 30% of them have dysmenorrhea, 20% metrorrhagia, and dyspareunia occasionally. The symptomatology would change in different people. Asymptomatic women, it would be a coincidental discovery, transvaginal ultrasound scan or an MRI, or coexisting with other pathology. Some may have an AUB, excessively heavily bleeding complaint that correlates with severity of adenomyotic process. We will see them in a little later. Dysmenorrhea in up to 50% of women with adenomyosis, that correlates severity, pressure symptoms on the bladder and bowel from a very bulky uterus, not very common. Infertility, miscarriage, and pregnancy complications are rare with an adenomyosis, but we have changed now, and even women come with infertility as well now. Adenomyosis associated pathologies, I'm sure you know that adenomyosis can be coexistent with leiomyoma, pelvic endometriosis, a polyp endometrial hyperplasia without atypia, with atypia, and of course an adenocarcinoma.
Govind bolo Hari Gopal bolo.
Vishnu, the protector, how is he going to help us to diagnose adenomyosis? Menorrhagia, dysmenorrhea, and a multiparous woman in her late 40s, as what I told you, with a diffusely enlarged uterus of 10 to 12 week size, not crossing the pelvic brim. Oh, although those signs are gone nowadays, the adenomyosis can cross borders and can go to any size now, and which is soft and tender. Oh, that was diagnosis some time back. Maybe suggestive, but not diagnostic. Clinical diagnosis is not made in 75% of patients, and it is overdiagnosed in 35% of patients, and that is where we stand some time back. The transvaginal sonography says blurring of endomyometrial interface, subendometrial linear striations, echogenic nodules, asymmetric myometrial thickness, myometrial cysts, and the fan shape, which Dr. Suresh just mentioned, are all diagnostic. Or MRI, sometime back we would not say MRI because in the exams we would be failed if I say MRI for adenomyosis, but today probably MRI is into the armamentarium of diagnosing adenomyosis. Low signal intensity myometrium surrounding normal high signal intensity endometrium, giving a beautiful honeycomb appearance, and so MRI seems to be more sensitive in diagnosing an adenomyotic area. External adenomyosis is something which we have to put out newly and tell women that adenomyosis within the myometrium alone is not adenomyosis. You could have adenomyosis outside the uterine cavity also. What is that? External adenomyosis, development of deep infiltrating adenomyosis or external adenomyosis is enigmatic, elusive. Mechanism can be so many. Location could be on the bowel, the rectovaginal septum, bladder, uterosacral ligament. This explains the frozen pouch of Douglas due to the RIV endometriosis, severe uterine adenomyosis in a peritoneum, otherwise free of endometriotic location. But then, ladies and gentlemen, now see what's happening. Oh, we have changed those days. That was then, but this is now where women live and men live in relationship. Oh, here again, what happens is the endometrium and the myometrium lives in a beautiful live-in relationship, and we give the new terminology called archimyometrium. The uterus is composed of two phylogenetically and ontogenetically different structures. The inner structure, the endometrial, subendometrial unit, is phylogenetically the archimetra. Ontogenetically, the archimetra is of paramesonephric origin. The outer structures of the uterus, the stratum vasculaire and the supravasculaire of the myometrium, are phylogenetically and ontogenetically younger and not of Mullerian origin, that is the neometra. They are derived from the serosal mesenchyme covering the primordial uterus, so they are definitely different. The archimetra is composed of the endometrial glands, the endometrial stroma, and the subendometrial myometrium, also termed as the archimyometrium. Hyperestrogenism and hyperperistalsis of archimetrium may contribute to adenomyosis. Heavy bleeding. We said some time back, HMB correlates to adenomyosis. HMB positively related to the depth of penetration of adenomyotic gland. Grade 1 adenomyosis subbasalis, identification within one lobar field below the basal endometrium. Grade 2, penetration beyond the mid myometrium, and grade 3 is penetration beyond mid myometrium. In grade 1, 60% had HMB, and grade 2 and 3, only 42% of them had heavy menstrual bleeding. So they correlated with the penetration also. Coming back to classification and reporting systems of adenomyosis, we've changed a lot from what we had, the transvaginal sonography, and a part of it was already covered by Dr. Suresh. The morphological uterus sonographic assessment based on the system. Of course, here you have to think in terms of the presence, the location, differentiation, cystic, non-cystic, layer, inner type or middle type, outer type, which you will see in the next slide, just like the Dashavataras of Vishnu, extent, and of course the size. So you need to report on all these parameters and only then say that reporting is complete with adenomyosis, and just not say it's a uniformly enlarged uterus, correlate clinically. That's what the report comes. That's not what we expect. And this is the transvaginal ultrasound based sonographic assessment, where you do a diffuse adenomyosis of the outer myometrium, diffuse adenomyosis of the inner myometrium, focal adenomyosis of the outer myometrium, focal adenomyosis of the inner myometrium, and of course, a beautiful adenomyoma, which Dr. Sunita will be able to excise very beautifully. But the other ones, I don't know how she will excise it. A sonographic classification of adenomyosis, inter-observer reproducibility, the evaluation of type and degree of the myometrial involvement came a little earlier, a beautiful paper which came out, which said ultrasound characteristics of 2D ultrasound features using diffuse adenomyosis, focal adenomyosis, and an adenomyoma, a correlation to the previous picture which I showed. And of course, they would do a mapping based on that. They will give a score here, a diffuse adenomyosis of the junctional zone, a focal adenomyosis, focal lesions with the outer myometrium, and a focal adenomyosis of the junctional zone, and of course adenomyoma. All of them are different, and you have a score which is very different here, and you will be able to see the scoring pattern, and we need to score them also, where you have a score of 1, 2, 3, 4, and then overall you score. And the extension of each type of adenomyotic lesion in the external myometrium and in the junctional zone was divided into 4 grades according to the ultrasonographic features. Shiva, the embodiment of grace, is the person who always treats and gives solutions. How does he give us solutions to treat adenomyosis? Coming to medical management, you have the LNG IUS, the danazol loaded IUS, which is yet to come to India, the GnRH agonist and the aromatase inhibitors. We could try all of them. The LNG IUS will probably cures dysmenorrhea. 20% of women on LNG IUS were amenorrheic after 1 year's use while still continuing to ovulate. Intermenstrual spotting, bleeding during the first few months is a disadvantage. It deserializes the endometrium, followed by atrophic changes, and reduces the menstrual blood loss. Downregulation of estrogen receptors, deficits shrink in size, and it definitely helps. So it is a promising treatment for adenomyosis, no doubt about it. And having said that, the danazol IUS, manufactured by Fujilatex, Tokyo, Japan, is a very common usage in Japan and areas around Japan, contains 300 to 400 milligrams of danazol, a drug which we had given off long time back because we had only oral danazol, and we did not give that because of the incidence of side effects, side effects more than the effect, due to the hirsutism and baldness and male effects, and so we did not use it. But now it's a locally acting danazole, so we could use them similar to the copper iodide due to thicker anteroposterior diameter of the stem and no systematic side effects of danazole. I'm sure we'll be able to get it very fast in India, and then probably this we will start using it much more than that of the LNG IUS system. The generic analogs, similar to any endometriotic effect, usually 3 to 6 months, and reduces the pre-op blood loss and size of the adenomyotic nodules, but they have their own side effects, which I'm sure Dr. Dr. Lakshmi, which just now a couple of minutes back, she enriched with us. And so I don't want to repeat the side effects of generic agonists. The aromatase inhibitors, the anastrozole, could be combined with the generic analog and found to be a very effective novel treatment for endometriosis. Only no, even for adenomyosis, it worked very well. And so that is something which is coming up, which we have not been using quite well. Oh, we have the novel techniques like the uterine artery embolization, which Dr. Lakshmi did mention for myoma. We could do that for adenomyosis also. Reduction in size, patient satisfaction, pre-procedural MRI to arrive at a correct diagnosis. And we use a PVA size of 150 to 700 micrometers in size to be used. Success rates are good, but then we need more RCTs to be weighted because we don't know fertility after uterine artery embolization. We're not very sure of. The MRI-guided focused ultrasound, I'm sure we did mention it for the myoma, has excellent anatomic resolution, very high tumor sensitivity and high thermal imaging sensitivity. Combination of MRI for planning and guiding for treatment is a non-invasive thermal therapy, overcoming a lot of potential concerns of FUS, but then not available everywhere, and probably cost is an issue. And so we need to use this more often to get into some consensus before coming into a recommendation or a guideline. Surgical treatment, the last part of my talk, Cullen distinguished 3 classes of adenomyosis: the submucous, intramural, and subserosal retroperitoneal adenomyoma. What I'm trying to say with this particular slide is that you'll see the pictures in the next slide. When you have an adenomyoma and you treat the adenomyoma in the uterine cavity, in the uterine myometrium, you do a hysterectomy and take it off. But if the patient has adenomyoma in the pelvic diaphragm or somewhere in the rectovaginal nodule, she is not going to be relieved of the pain which she came to you with. So hysterectomy is not the only treatment for adenomyoma. We need to locate where the adenomyoma is and then probably treat. If it is going to be retroperitoneal, you would not be justified in doing only a hysterectomy for that particular lady. This classification of 3 types of retroperitoneal adenomyoma. Type 1 is the rectovaginal septal nodule between the wall of the vaginal mucosa and the anterior wall of the D-rectal muscularis. Type 2 in the posterior vaginal fornix. This is why they have a deep dyspareunia, or you can feel the nodule. And type 3 is a diabolo-like rectocervical nodule on the posterior side of the cervix, and the continuum exists with an adenomyotic lesion on the anterior rectal wall. Excision of the nodule and deposits is the treatment of choice to alter symptoms like chronic pelvic pain, deep dyspareunia, dysuria, dyschezia, and hysterectomy here will not help you, ladies and gentlemen. This is the type of type 1, type 2, and type 3. Where I said the rectovaginal nodule, this is the nodule, this is the septum, and this is the diabolo-like picture, and for which you need to excise the nodule, probably using the Peter Menler's nodule from Sydney, and he was the one who found out the Peter Menler's dilator, which you put into the rectum and go on. Coming back to the last step, which is hysterectomy, primary diagnosis and therapeutic strategy for adenomyosis. It is definitely a therapeutic strategy. And let me put the point here that a vaginal hysterectomy is preferred in an adenomyotic uterus. Increased risk of bladder injury in vaginal hysterectomy needs to be taken into consideration with the paper which put forth, because the myometrium gets enlarged irregularly and we need to push the bladder quite well. So we need to be quite cautious, but still VH is probably preferred over the other routes of hysterectomy, but that depends upon the choice of the surgeon and the patient on what discussion you would go on to. And so the Trimurtis have come and helped us to diagnose, manage, and of course to treat a patient with adenomyosis. To conclude, basic pathology of adenomyosis is the same everlasting dogma. Many pathologies may co-occur with adenomyosis like fibroids. MRI seems to be a more sensitive diagnostic tool. Just like endometriosis, adenomyosis may be also located elsewhere. Concept of archimyometrium is new. LNG IUS Danazol IUS, GnRH agonists, and aromatase inhibitors are promising medical treatments. Uterine embolization, MR, IFUS, and selective surgical excision or conservative surgical options. Hysterectomy is not the last. Yes, it is the last. Hysterectomy is not the best, but the last resort for treating adenomyoma. Thank you very much, ladies and gentlemen. Let me stop staring. Happy to answer questions.
Palaniappan, it was a fantastic talk. Fantastic. As Sunita was saying, she loves to hear your talk. I too. I mean, it was a novel way of delivering a talk. And you also covered all the aspects, all the treatment modalities for adenomyosis. So it was fantastic talk, Professor Palaniappan. And if there are any questions, Sunita, you want to say anything before you want to go? Because I know you are standing.
No,
Standing, your car is standing on the road.
No. Now I have moved on because I felt I have a good range and 60 kilometers more to go, 7:30 function. But I think today I could listen to all because I was absolutely free, and the standard of your webinars, Lakshmi, hats off to you. Hats off. As an ICOG chairperson, the way you have taken the academic wing of our FOGSI, unparalleled. It's very difficult for everyone to match now to you.
Thank you, dear. Thank you so much. But I give full credit to all the conveners. They are doing a fantastic job and I am just taking the credit.
That's what the key is now. You create the ideas and you get the team to implement that.
Yes.
The creator is you and you get right people. So unless you have a team now, you cannot work. You cannot be beautiful.
It's a teamwork. No doubt about it. Thank you. Thank you so much, Sunita, for logging in and sharing your wisdom and your expertise with our dear delegates. So, Professor Palaniappan, you want to say something?
I'm just waiting for some questions to come, and there are a few questions here.
We will wait.
There are a few questions for Dr. Sunita also, and I'm happy she's here. She's got 15 more minutes to travel and drop back. A nullipara 13-year-old with mild to moderate symptoms, multiple fibroids, largest being 6 to 7 centimeters, not ready to undergo MRI, or whether myomectomy followed by hormonal IUD or hysterectomy. You have said it's not hysterectomy. This is from Dr. Alka Kute. Largest being 6 to 7 centimeters, not ready to undergo MRI. So I'm sure we will do a myomectomy for her, followed by hormonal IUD if required, and definitely not do a hysterectomy. I'm sure Dr. Sunita will agree with me.
Absolutely, at 39 myomectomy, but sometime if there are like 10, 12 myomas, she has said multiple myomas. So if the uterus is studied with, I have seen so many cases where 30 myomas in the uterus in 39, I sit and I will do hysterectomies. If the myomas are less than 6, 7 in number, because you know what, they will have many siblings.
Yes.
Completed childbearing. 40 again she will come with 45, she will come another set of myomas. Multiple is very vague. So if there are 6, 7 myomas, no sibling, I will go only. But many a times, if you seen my photographs, hardly myometry is seen. Then we have to counsel her that, listen, I'll take out your uterus and tube. As parity, you are not interested. Mainly what you need is the ovaries, and I'll ensure that maximum ovarian supply. Also, I'll keep when I'm keeping your ovaries. But you are not going to have a hormonal imbalance. These patients will need a counseling. But obviously, if you come with the 30 centimeter myoma, but single myoma and 48 conserve uterus.
Yeah. Thank you, Dr. Sunita. We have one more question. Role of mifepristone. I think, the dosing of mifepristone is an issue. The recommended dosage is 25 milligrams per day. We have mifepristone available as 200 milligram tablets for your medical abortion, and some companies manufacture mifepristone as 100, but then we don't have 25, and it's not a vitalized tablet where you can't cut the tablets and give them. And we had done a study with mifepristone, works quite well, but then dosing of mifepristone of 25 milligrams is the question, and so that is exactly the difficulty in using mifepristone. Oral misoprostol, again, the same thing, 25 milligrams of misoprostol is not very easy to get, and they have other side effects like the GI symptoms, and that is why we're not able to use them. Ulipristal is a promising option. Ormeloxifene has been used quite well twice a day some time back, but then the bleeding pattern comes back once you stop ormeloxifene, and that is why not a very great idea to use. Ulipristal, coming back to, I thought we should have a discussion on that, is used quite well now, and in the US and UK is probably the panacea for medical management of fibroids. But then in between we had a couple of drugs producing liver function test modifications, and so some companies started banning the usage of ulipristal, but then the Drug Controller of India again has allowed usage of ulipristal, and we have enough evidence to say Pearl 1, 2, 3, 4 study has come out, and the Pearl studies have confirmed the usage of ulipristal, and so we could probably use ulipristal with a single condition, saying you will do ulipristal, give ulipristal acetate after having done an LFT, and then at the end of the study, end of the 13 weeks of treatment, you will again do an LFT, provided it is quite normal, and you will convince the patient that she will bleed only within 13 weeks after producing, and a period of amenorrhea in between. If these conditions are accepted, then of course you could go ahead and give usage of ulipristal, yes. And so these are the questions. And one 34-year-old patient has 8 centimeter posterior wall adenomyoma and a diffuse lithic anterior wall. How will you proceed? Pain is the only complaint for her 34-year-old. So I wouldn't think in terms of a hysterectomy. I would probably send her to put a levonorgestrel releasing IUD because the posterior wall, or I would send her to Dr. Sunita for excision of the adenomyoma. Isn't it, Dr. Sunita? I'm sure you will excise adenomyomas also as beautiful as the myomas.
See, 8 centimeter and pain is a symptom. Probably 8 centimeter is too big for a medical line of treatment immediately. No harm in trying for a medical line of treatment because whatever said and done, 70-80% you will be able to excise. If another 4-5 years, this lady will need another surgery. So I might give her a 6 months of amenorrhea, and if adenomyoma substantially reduced more than 50%, and if it is not compressing the cavity, I'll put the Marina for this patient, and I will try and work on a medical line of treatment. In adenomyosis at 34, I try to work with medical line of treatment as much as I can, and if it is such an unbearable pain that it is not getting relief, then surgery is the only option. Many a times I do adenomyomectomy with the presacral neurectomy also. While in spite of adenomyoma, because the anterior wall is diffusely thick, you should be putting her on Marina post-operative otherwise also.
Thank you. That is fantastic. One more question from Dr. Kamala saying treatment of diffuse adenomyosis in a 30-year-old infertility patient. I think because she's got a diffuse adenomyosis, 30-year-old infertility, I would not do any surgical option. I would go ahead and do medical and then think in terms of inducing ovulation and going in for ART and then making her pregnant as soon as possible. Is that right, Dr. Sunita?
Yeah, now diffuse adenomyosis is always challenge. How diffuse it is, mild, moderate, severe. So I will do, as you said, I will take out the eggs, I will freeze her embryos, and I'll give her 6 months to 9 months amenorrhea. Now we do the mapping of these. I have my adenomyosis classification. Some other time, Lakshmi, we can cover it for these people.
Sure.
For infertility, when to give medical line of treatment and when to give, where we have received just award-winning paper recently. But diffuse adenomyosis, 6 to 9 months of a medical line of treatment, it shrinks to 40, 50, 60%. It is not only the mechanical factor, but Th1 immunity is going to be high and implantation will be a trouble. Many a times, if they don't respond, then unfortunately, with moderate to severe adenomyosis, surrogacy is the only option these people will have.
Thank you. The next question is from Dr. Neerja. How aromatase inhibitors are given? Okay, aromatase inhibitors at the moment we have the anastrozole and then we have the FOGSI latex thing coming in picture. It's not come to India yet, and so it is not being used very well. Dr. Atul Munshi ji from Ahmedabad has appreciated, saying excellent webinar. Thank you, Atul Munshi ji. Thank you very much. And yeah, Dr. Lakshmi Shrikande, over to you for the final messages. We are somewhere near 6:55. We usually finish 6:55. Yeah.
No, it was a fantastic webinar. I'm sure each and every delegate must have been benefited with the expertise and wisdom of all our esteemed faculties. And Palani, you very well drafted this module. The selection of topics and speakers were simply superb. And I give full credit to you, Sunita, and this is really credit to Palani for today's whole program. And it really went on well, Palani. So kudos to you.
Thank you. Thank you, Dr. Lakshmi. And if there are no more questions, if anybody wants to say anything, Dr. Sunita, all the best to you in all your endeavors. And you're traveling the journey and you reach the destination fast and in the most successful way. And
thank you for giving me a company for my travel to 3 hours travel from Pune. I got a beautiful company of you and Lakshmi. What else I want?
Thank you, dear.
Thank you very much.
Your talk was
Thank you.
simply superb.
Thank you. Thank you.
So I think we can
close the recording.
Yeah. Mitali, stop the recording.
Yes, ma'am.
Yeah, and we can end the meeting. So see you all for next masterclass next month. It will be on infertility, and the dates and all will be posted on ICOG website. So please visit the ICOG website for the final calendar of the June month. So see you all. Bye.
And